Yeah, mine's Friday.
Oh, good.
Okay.
I just wrote a letter and said we got it all. So, that's how it works.
Cool.
Excellent, excellent.
All right.
Thanks for vouching for us.
Yeah.
Your text probably ends.
What's that?
I forgot your text probably ends.
Oh, good.
Should we get started? Everybody's here? Probably everybody's here.
How long is your presentation?
Well, usually it's 4 hours.
Yeah,
but
okay.
Yeah.
2 hours.
Well, I'll be back up.
Yeah, sorry about kind of the mix-up. We've had a couple of instructors that have had to change things, so we're kind of changing things around. But Thursday will be cardiovascular and toxicology, right? Is that what's on your schedule? The 11th?
The schedule says immunologic toxicology.
Oh, it's going to be cardiovascular. And today is respiratory, chapter 17. So we can get through that. And then Kurt's going to do endocrine and hematologic. Okay, so respiratory distress, dyspnea, difficulty breathing, whatever you want to call it. This is one of the most common calls that you're going to go on in your career in EMS. Think about how many times you go on a respiratory distress call, or how many times you go on a call and it's really not what dispatch told you, it's a respiratory distress problem. Lots of different symptoms, lots of different problems, a lot of different things that can cause respiratory emergencies. They run a gamut. I mean, just about anything that you can think of can cause a respiratory problem. Your job is not to determine the cause. Your job is to take care of the patient. Figure out what you need to do to get them to the hospital and take care of them. So you don't have to diagnose a respiratory problem in the field, but we do want you to understand some of the processes that lead up to respiratory distress and difficulty breathing and the major things that you can do to help people on the way to the hospital. Respiratory distress and not getting enough air and having this trouble breathing can really be terrifying for your patient. So remember that. Be compassionate with these people. Respiratory distress is probably one of the most terrifying things that people go through and experience. Just think about it. You know, if you're having trouble breathing, what does that do to you? How does that affect you emotionally? How does it affect you physically? So, most of the time you're just going to be taking care of the symptoms. You're going to figure out what the problem is with the patient based on their symptoms and take care of that. But you're going to just take care of the symptoms. A lot of the times there's nothing you can do for the actual cause. And one of the biggest things too is remember to treat the anxiety these people are feeling. You're going to have to talk to these people. Sometimes you're going to have to coach them, kind of coach them about their breathing, reassure them. That's some of the most important things that you can do for these people is coach them, reassure them, and try and get them breathing somewhat normally. So we're going to do a real quick review of the respiratory system. We went over this a couple of weeks ago, so you should be familiar with it. Upper respiratory system is basically just the nasopharynx, oropharynx, trachea, and the bronchi here, where the trachea bifurcates into two main branches. That's the upper respiratory system. We talked about gas exchange before, where you exchange deoxygenated blood in the lower respiratory system for oxygenated blood. In the alveoli are surrounded by capillaries. Remember, these capillaries are so small that they have one red blood cell that can go through at a time. Now they're stacked up on each other, but only one can pass through at a time. This is where all of the gas exchange occurs, right here in these alveoli. And unoxygenated blood comes in, gas exchange occurs by diffusion, nutrients are passed into the bloodstream, oxygen is passed into the bloodstream, the carbon dioxide is passed into the alveoli, and the oxygenated blood and nutrients go out through the arterial system, and carbon dioxide and waste products are exhaled out. Just a little bit different picture. So we talked before about inspiration and expiration, what they do. Ventilation is just the process of moving air into and out of the lungs. That's all it is. Respiration, that we'll talk about in just a second, is just the process of gas exchange. Internal respiration is gas exchange, and it all occurs in the alveoli down here. So the stimulus for your respiratory system is in the medulla, in the brain, and it's usually worked by the amount of carbon dioxide that's in the lung. That's what is your initial respiratory drive. The way that it works is that respiratory center says you need to take in a breath to get some oxygen and blow off some of this carbon dioxide. Basically, that's how the respiratory system works. So your diaphragm contracts, and remember, inside the chest, inside the thoracic cavity, you have a negative pressure. So when that diaphragm contracts and moves down, it pulls air in. It feels like you are pulling air in, but actually what it is, it's your diaphragm contracting, intercostal muscles are contracting, and they're making that space inside your thoracic cavity bigger so that the lungs can fill up with air. Everybody understand that? Understand the negative pressure concept? Okay. When you're going to exhale, there's sensors that regulate how much air is brought into the system, and it just basically tells the diaphragm to relax. Diaphragm will relax, the intercostal muscles relax, and it forces the air out of the lungs up through the upper respiratory tract and out. Expiration lasts twice as long as inspiration. There's a lot of reasons for that. Just remember that expiration takes longer than inspiration. So in order for the body to receive nutrients, you have to have adequate perfusion. Some of the problems that occur with inadequate perfusion is upper airway obstructions, lower airway obstructions or lower airway problems, trauma to the chest wall, don't have as good a movement in the chest wall, or neurological problems. Some of those are based in the brain, like strokes or emboluses in the brain that cause problems. Just remember where all of this stuff kind of starts and stops and what occurs with the whole ventilation and perfusion. Any questions about that? We went over this a couple weeks ago, so it should all be pretty familiar to you. The two types of cells, the pneumocytes and the alveoli, type 1 just allows for gas exchange, and type 2 makes up the type 1 cells and also makes the surfactant. Remember when we talked about the respiration inside the lungs, what did the surfactant do?
Keeps it lubricated and.
Yeah, keeps the alveoli lubricated and basically keeps them open. Without surfactant, those alveoli will close up, they'll shrink up, and they'll stick together so that they won't be able to expand. Those need to expand so that you can have adequate gas exchange. So there's a lot of different problems that relate to ventilation and to inadequate gas exchange. When you think about the alveoli, just think about like a balloon at the end of a straw, because that's basically what they are. They're a balloon at the end of a straw. If there's any foreign material that gets in that straw, what happens? Yeah, you can't blow up the balloon, right? And sometimes the balloon can't deflate. So it's a pretty easy way of looking at the alveoli and how they work. These pulmonary capillaries that are part of perfusion are really small. Like I talked about before, the red blood cells can only flow through in a single file line. So if there's anything that disrupts that, those red blood cells can't flow through the capillaries to perform adequate gas exchange. When the carbon dioxide starts getting up, the respiratory center becomes less efficient at being able to control the respiratory system, and you'll start retaining carbon dioxide, which is not good. So what happens then is there's a backup system that will start controlling it by the oxygen level in your blood. So if you get or get hypoxic, that part of the respiratory system will take over and tell you to take a breath until the whole system can kind of reset and that medulla starts sensing the carbon dioxide levels again. If you get too much carbon dioxide in your blood, it causes respiratory acidosis. What does acidosis do? You remember? Okay, pH drops. That's acidosis.
But it increases your breathing, right?
Yeah, it'll increase the breathing because you want to blow off that carbon dioxide. Also can cause muscle cramping, and it creates what they call a lactic acidosis. It's not good for any of your muscles, especially for the heart. When that heart gets acidic, it doesn't pump as well because it doesn't get the exchange in it that you need. Some of the things that cause hypoventilation, we already talked about. Anything that will impair lung function and the ability to inflate and deflate the lungs. Anything that impairs the mechanics. Usually what that is trauma, like we talked about, and anything that reduces the respiratory drive. Hyperventilation is kind of just the opposite. You've all seen hyperventilation in the field, right? People that are breathing too fast. What happens when people breathe too fast and they get Yeah, carpal pedal spasms is a classic sign of hyperventilation. That's because of that lactic acid buildup, causes those muscles to cramp, and it really starts in the periphery, and the carpal pedal spasms are what people notice a lot. Once they have carpal pedal spasms, they've been blowing off a lot of CO2. So, pretty important that you get that regulated.
Well, eventually won't they just pass out and like the body?
Yeah.
It's kind of try to reset itself, isn't it?
Well, yeah, eventually they'll pass out and they just won't breathe for a minute. So,
But then they'll
yeah.
should start.
That's what'll get that carbon dioxide built back up.
I don't know what carpal pedal spasms are.
Oh, okay, sorry. The hands will cramp up. They'll look like claws. Their feet will cramp up. Their toes will cramp up. Hyperventilation, one of the earliest signs is their tongue and their lips will get numb. They'll experience numbness, and they're breathing really fast. They're pretty anxious, and especially once these carpal pedal spasms start, they really freak out because they don't know what's going on, and you really have to coach them to get them to start breathing normally. There's a lot of different things you can do for hyperventilation. One of the things I like to do, get a glass of water. Give them a glass of water, and as long as they can hold it, have them take little sips of water. Because what does that do?
They just have to stop breathing for a minute.
Yeah, exactly.
Drink the water.
Yep, exactly. They can't drink these little sips and breathe at the same time. So use that to help them slow down. There's a lot of other things you can use. Have them rebreathe into a paper bag. You can even put an O2 mask over them. Just don't give them O2. Let them rebreathe into that. Okay. Any other questions about hyperventilation? All right. So what are some of the causes of difficulty breathing and respiratory distress? Yeah, okay. Asthma.
Heart failure.
Yep, heart failure,
COPD.
pneumonia, anything that's going to affect the function of the lungs and the respiratory tract. Obstructions. How do we recognize an obstruction?
Auscultate.
Okay, even before that.
Sounds of breathing.
Yeah.
Or lack thereof.
Sounds of breathing, work of breathing, just watching somebody, or even just history, you know. Yeah, I don't know what happened. He started choking and now he's turning blue. Okay. What's that? That's an airway obstruction. They're not getting adequate gas exchange. The pleural space filled with air or fluid. What's a couple of those problems? Pneumothorax, yeah, or hemothorax, or atelectasis, where you get an infection in the lining of the pleural cavity and it starts filling up with fluid. There's a lot of reasons. Hay fever, you know, anaphylaxis, trauma, cystic fibrosis. Just, we can go on and on and on and on and on about reasons that people might have difficulty breathing. So some of the signs: air hunger. They may have chest pain. They may be complaining of chest pain or chest tightness. Could be from a lot of different things. If they have cardiopulmonary disease, it's a really common problem and a really common sign of respiratory distress. If they have pain somewhere, they can have rapid shallow breathing. What about trauma victims? They have extremity trauma and a lot of pain, fractures. What's the first thing they do? Yeah, they start breathing fast because they hurt. Not really a pulmonary problem, but it's just a reaction to their trauma and to the pain. Lots of different diseases. We've kind of talked about some of them. Infection is probably one of the most common causes of respiratory distress. What are some of the infections that you can think of that could cause that? Pneumonia. What else?
Epiglottitis.
Yeah, epiglottitis. That'd be an upper airway. Bronchiolitis in kids. RSV in kids.
Upper and lower.
Yeah, lower. That's lower. Yep. Even just a cold can cause respiratory distress sometimes. People's sinuses get impacted. They get sore throats, and so they'll have edema in their throat. What does that do? That narrows that whole upper airway. Causes a little bit of problem getting the air into the lungs where it's supposed to go. If you get infections in the lower airways, it causes the alveoli to have problems, and the gas exchange won't be as well, it won't be as effective. So just be careful when you're evaluating these people, especially somebody that's got a recent history of a fever and a cough. Obviously, they've got some kind of respiratory problem and might have some kind of infection that's affecting that ability for that gas exchange to occur. Pulmonary edema. How many times have you seen pulmonary edema in the field? You've probably seen it and not recognized it. People with respiratory distress, especially if you listen to them, they've got crackles in their lungs because of the fluid buildup in their lungs. That's pulmonary edema. Sometimes they'll get what we call dependent edema in the lower extremities, where they get their ankles will swell up, their feet will swell up. They'll get cankles. You know what cankles are? Yeah, big ankles. Okay. One of the ways that you can tell that they've got edema down there is if you can press on that skin. Just press on it. See if it leaves a dent. If it leaves a dent, that's what we call pitting edema. So they've probably been suffering from this for a while. And depending on how long that dent stays there, it will kind of determine how bad the edema is and how quickly they need to take care of it. Not everybody with pulmonary edema has heart disease, though. It can be other causes. They could have pulmonary function problems. So people with pulmonary edema, a lot of times, they'll have the shortness of breath. They'll be orthopnic. What's that?
They only breathe well sitting up.
Yep. They have to sit up to breathe. Or these will be the people that are tripoding. You know what that is? They're sitting up, their elbows are on their knees, they're kind of hunched forward a little bit, trying to get in as much air as they can. So watch for some of that. One of the biggest problems with that, with breathing like that, is they get fatigued pretty easily, especially kids and the geriatric population. Kids will compensate and compensate and compensate, and then they fatigue, and they will fatigue like that. And pretty quick, they're not in respiratory distress anymore, they're in respiratory failure. And it occurs really fast. With kids, you've got to be really careful. We talk a little bit more about this in PALS with the respiratory distress with kids, but just be real careful with kids. The pulmonary crackles we talked about before. You'll get crackles or wheezing in that lower airway because of the fluid down there. And basically what this fluid does is it separates the alveoli from the capillary beds. And the respiration is ineffective at that point. COPD. What's the most common cause of COPD? Smoking. Yep. So if you smoke, quit. If you don't smoke, don't start.
That's good advice.
Yeah. I smoked when I was younger. First, because I thought it was cool. And then I smoked all through paramedic school just to get through paramedic school. But in paramedics, the reason I quit is when we were in paramedic school, we got to go to the medical examiner's office. And they showed us the difference between smokers' lungs and non-smokers' lungs. And I went, holy crap, that's not good. When I smoked, cigarettes were 35 cents a pack. You could buy a carton of 10 for $3, which is about what cigarettes cost now.
You almost couldn't afford not to smoke.
Right, right, yeah. So, but yeah, as soon as I got out of paramedic school, I went, okay, all I'm doing is sucking this bad stuff in and blowing it out. It's not doing me any good, and it's costing me money. So, I quit cold turkey. So you'll get obstructions in the bronchioles. They'll constrict. A lot of times you'll get fluid built up in those bronchioles. These people, one of the biggest problems is they retain CO2 and they retain the air. They can't get the air forced out of their lungs. They have a lot of mucus in their lungs. They'll be coughing. They'll cough up goobers, and be careful when they're coughing that they don't cough up a goober on you. They're really prone to pneumonia. A lot of times COPD just eventually develops into emphysema. And that's just basically where the alveolar walls have had so much crap in them that they just don't work anymore. They just stop working, and you don't have effective gas exchange. So this feller here, what's he look like? What's he doing? Tripoding.
Muscles.
Yep, yeah. Whoops, sorry. You can't really see it, but a lot of these people will also have a barrel chest. Their chest will look like it's expanded all the time. That's because of air trapping in there. They can't get that air out. These people will have chronic fatigue. They'll really be working to breathe. It's really hard for them to breathe.
Why is it they exhale through the pursed lips if they're trying to get as much air out as possible and there's already obstruction in the lower airway?
They're trying to blow it out.
But isn't that, I mean, that's creating more of a restriction, right?
It does.
Are they trying to increase the expiration time?
Yeah, they're trying to increase the expiration time, and it's just a natural reaction. Instead of going, that's not a natural reaction. To blow stuff out, it's like blowing out a candle, or blowing through a straw.
Gotcha.
This is just kind of a progression of COPD. These are normal bronchial, normal alveoli here. You start getting inflammation in the bronchioles. The air gets trapped in here, and these alveoli get bigger and bigger. And eventually they get to the point where they get blown up like a balloon and they just don't function anymore. Plus you can get mucus in here in the linings of the bronchioles. Now remember, these are teeny, teeny, tiny. These bronchioles are not very big. They're like the size of a strand of hair almost. They're very, very small. Asthma. Anybody in here have asthma? Have kids that have asthma? Wow. Okay. Asthma is pretty scary. We see it a lot in kids. There are adults that have it. But what it is there's just a lot of mucus production and bronchial spasms and spasms in the bronchus. And they get really narrow. Narrows that bronchus down. In fact, there's a picture of it right there. There's mucus in there. Plus look how thick the lining of that bronchiole is. Pretty narrow already. So when that thing gets narrow and you get a lot of mucus in there, causes a lot of problems. It's usually a chronic disease. A lot of times kids will outgrow it once they become teenagers or young adults. Biggest problem is taking care of it. So what do we do for somebody that's having an asthma attack?
Nebulizer, help me with that.
Okay.
Oxygen, CPAP.
Okay. Oxygen. Talk to them, coach them. Kind of depends on what the problem is. Sometimes they'll have, it's because of an allergic reaction. A lot of times if they have an allergic reaction, a lot of these people don't have chronic asthma. But if they have allergies, like little kids sometimes have food allergies. And you'll get the kid that has allergy to peanuts or to nuts or something. They go to school and eat something at the cafeteria and it's had peanuts in it or had nuts in it. They end up in the nurse's office with respiratory distress. And that's the same thing. Those bronchioles are shrinking up and they get mucus production, hard to breathe. There's also a phenomenon called exercise-induced asthma. Usually occurs with older kids and teenagers. You'll see this in athletes every once in a while. They'll get exercise-induced asthma, where all of a sudden they have been out working out and they can't breathe. Emotional distress is a real common cause of asthma, especially for kids, and upper respiratory infections. So how do we treat them? Oxygen, number one, especially if they're having real difficulty breathing. Number two, what medication can we give them? Albuterol. Most of these people have inhalers called an MDI, a metered dose inhaler. And it gives a specific dose of usually albuterol or sometimes racemic epi. And that'll open up those airways. But sometimes that medication doesn't work and we have to give them the albuterol. nebulized albuterol. How's it delivered? Nebulizer. All of you familiar with the nebulizers? Okay. If you're not, get familiar with them. Go out in the field, have your partner or have the paramedics at your station or anybody that knows how to use it, put it together and use it. How many liters a minute flow do you use with a nebulizer? 6. Yep. If you get much more than that, it starts blowing out. It doesn't mist properly, and so you don't get that mixture properly into the airways. A lot of times you'll have to coach these people on breathing, especially kids. They don't like to have that piece in their mouth. They make spacers, and I don't know why we don't carry the spacers, but spacers work really good for kids because they don't have to bite down on that mouthpiece and try to inhale with that mouthpiece in their mouth. Anaphylaxis. Common anaphylaxis causes. We talked about a couple of them already.
Bee stings.
Food allergies.
Bug bites.
Yeah. Insect bites, especially bee stings. Some people might not even know they're allergic to bees until they get stung and then start having severe respiratory distress. So, same thing, treated the same way. Oxygen, you give them nebulized treatments, just get those airways open. Spontaneous pneumo. What's the probably number one cause of a spontaneous pneumo? Or patient, I mean.
Tall male.
Tall, skinny males, usually between 17 and 25. It just happens.
What's the physiology behind that?
Their airways are long, they're just smaller. The airways are smaller. People with Marfan syndrome are really prone to spontaneous pneumos. Everybody know what Marfan's is? Marfan's is they're usually tall. Abraham Lincoln.
They have like super long arms and legs.
Mm-hmm. Long fingers, long arms, long legs. Abraham Lincoln supposedly had
That
Marfan's.
one guy that's had it.
Really?
Yeah.
Yeah. Yeah, I've seen a few people with it. It's they don't look really abnormal, but they look kind of gaunt. They look like they have poor nutrition and stuff. A lot of times you can get this from an infection in the lungs. You'll have infections in those alveoli, and it'll pop some of the blebs, some of these alveoli, and the air will just come out. The biggest problem is recognizing this. People, well, we'll go to the next slide. Altered mental status, they'll be tachypnic, tachycardic, they'll be, a lot of times they'll be hypotensive, they'll be hypoxic, cyanotic, and the breath sounds will be unequal. So when you assess people, when you're doing your assessments, I think I've talked about this before, listen to everybody's breath sounds. Everybody that you assess, listen to breath sounds. Just get used to doing it. Number one, it tells you what normal breath sounds sound like all the time. And number two, if there is something kind of funky going on, you'll recognize it, especially a spontaneous pneumo. One of the late signs of a spontaneous pneumo is this tracheal deviation. If they have tracheal deviation, they're in big trouble. They have a massive pneumothorax. Does everybody know what tracheal deviation is? Okay, I've only seen it a couple times in my career, but you'll notice it. Which way does the trachea deviate? Towards the pneumothorax or away from it? Away from it. So if you see it, you'll know which side to needle the chest on. Really, the only thing that we can do for these people in the field, if they're in really, really critical condition, is to needle their chest. You won't be doing that, but you may be assisting the paramedics when they do it. Pleural effusion is just a collection of fluid outside the lungs in the thoracic cavity. Could be from an infection, could be from some kind of congenital problem in kids, could be from cancer. People with lung cancer get pleural effusions a lot. They have to go in and get it drained. Not a lot that we can do for this in the field. We just need to get them transported, get them to ED, and they're probably going to have a paracentesis or a thoracentesis. That's basically where they just stick a needle between the ribs and withdraw the fluid. Pulmonary embolism. Anybody ever known anybody that's had a pulmonary embolism? Okay. Have you? Were you there and saw them, or just?
We got a bunch of guys on the job have PEs.
Yeah, we've had guys like that. Yeah, it happens. They're kind of scary. Basically, all it is a blockage of one of either the pulmonary artery or the pulmonary vein. 90% of the time, it's the pulmonary artery.
Actually, just to go back on that one, so you guys many of you know Stuart Wallace has been a partner for a long time. He's like, when he tried out for LA County, he had he was ripping up, trying to pull a hose up off the platform, and he has spontaneous pneumo. So he's like the perfect body type.
Yeah.
Spontaneous. So there you go. And so guys just at work all of a sudden have pulmonary embolism, like, and it's kind of weird because it just comes on fast and they can't breathe, and nothing you do helps them. So just recognize when you see that nothing we're doing is helping them, and start thinking pulmonary embolism.
Yeah, if they've got normal breath sounds and severe respiratory distress and cyanotic, consider it. They're not getting any gas exchange. That's the biggest problem with the pulmonary embolus. And it can either be a partial embolus, partial obstruction, or it can be a complete obstruction of that pulmonary artery. And if it's a complete obstruction, they're in really, really bad shape. They'll probably not survive a complete obstruction. One of the ways it happens is just damage to the lining of the pulmonary artery or the pulmonary vein. Hypercoagulability. For whatever reason, they've got an overabundance of platelets, and they're sticking together and causing clots. Deep vein thrombosis in the legs. That can occur from people that have had surgery recently, or who have been in bed for a long time, haven't gotten up and moving around. Postpartum is another reason for a pulmonary embolus, and it just happens related to childbirth. One of the guys I worked with in the city, his wife had a pulmonary embolus right after childbirth, and she's one of the 10%ers. She survived, but they did CPR on her for like 45 minutes. She survived, no brain damage. Well, he claims that she had brain damage. Anyway, so especially people that have had recent surgery and stuff, or postpartum female, if they have a sudden onset of respiratory distress, can't breathe, cyanotic, and they're hypotensive and they're circling the drain, just think about a pulmonary embolus. Can we do anything for it? No. Biggest thing we can do for them is oxygen and PUHA. Remember what PUHA is? Didn't I tell you what PUHA is? Pick up and haul ass. Okay. That doesn't mean drive 90 miles an hour. That just means get them to an appropriate facility as soon as you can. Okay. We kind of already talked about some of the signs and symptoms. Respiratory distress, they're going to be tacky both ways. Usually this is a sudden onset. They may or may not be coughing up blood. If they're coughing up blood, that's a really ominous sign. Airway obstruction, we've already kind of talked about airway obstruction. Yeah, we don't need to go over that, right? We've talked about airway obstruction in our airway class, right? Okay, all right. Sometimes people can get respiratory problems from inhaling chemicals, either at work or what's a really common thing that people mix together at home for cleaning?
Money and bleach.
Yeah. Yeah. Don't do that.
Why,
It's
mustard
not-
gas is cool.
Yeah. What's that?
Mustard gas is cool.
Yeah. Yeah. A lot of people get the cleanser out, the Ajax, pour it in the sink, and that's not working, so they think, oh, I know how to clean that up. We'll pour some bleach in there. No bueno. So if you go on to an industrial area and somebody's having respiratory distress, always think about some kind of environmental exposure, especially industrial areas. Cystic fibrosis is just a genetic disorder that kids have. There's nothing we can do in the field for cystic fibrosis other than to support them and get them to Primary Children's Hospital. Unfortunately, a lot of these people die in childhood. A lot of them don't survive past teenage years. Occasionally, you'll get a young adult that has CF, and they'll tell you they've got CF, cystic fibrosis, and they usually know kind of what to do for it and how to take care of it. But sometimes you just need to get them to the hospital. Some of the age-related problems, we already kind of talked about bronchiolitis. What's that real common in RSV? Little kids. 6 months to about 2 years is really common for RSV and bronchiolitis. So if they've had a recent history of fever and maybe a little bit of a cough or something and they're in respiratory distress, cyanotic, work of breathing is bad, intercostal retractions, suprasternal retractions, yeah, you need to get them to the hospital. Mostly they need antibiotics to cure this stuff. Croup, we talked about croup in the airway class. Everybody knows what it sounds like, right? Yeah, barking seal. Biggest thing there is a lot of times this occurs in the winter. It's kind of a seasonal type problem. Get them outside in the cooler air or humidified oxygen. That's about all that we can do for them. Epiglottitis. This is a real emergency. you have to be really careful. If you suspect epiglottitis, don't stick anything in their mouth. Don't use a tongue blade to push your tongue down and look in there or anything, because it can aggravate that epiglottis and it'll just swell up and get really, really angry. So if you have a kid, you go on, they're tripoding, having respiratory distress, maybe cyanotic, had a recent history of some kind of recent history of a fever the last day or two, and they're drooling and they're not talking, think epiglottitis. The only thing that you can do for them is they'll have to have a surgical airway of some type probably, if they really start closing off. Usually they'll end up with a trach at the hospital. Pneumonia, it's just an infection in the lungs. Geriatric population is really prone to pneumonia, and little kids with previous ventilatory problems are really prone to it. Kids on ventilators are really prone to getting pneumonia. Pertussis is whooping cough. We talked about it. Prevention is getting your DPT. You have to get in a vaccination every 10 years at the most. You have a puncture injury and it's been more than 5 years since your last DPT, you probably ought to get one. My wife actually had whooping cough about 5 years ago. And I came home from work and she was coughing and complaining that she couldn't breathe very well, and she started coughing and I heard it and I went, holy shit, you've got whooping cough. No, I don't. Yeah, you do. Got her to the doctor right away, and doctor walked in and she was coughing and he said, you've got whooping cough. She kind of looked at me and I just grinned. Yep, I diagnosed her. Pretty cool. Anyway, a lot of times these people have a recent history of fever again and very distinctive cough. A lot of these sounds, you can go on the internet and there's just tons of places that you can download breath sounds and stridor and whooping cough and croup and all that kind of stuff so that you know what they sound like. It's pretty interesting to listen to some of this stuff. Airway obstructions, foreign body airway obstructions. Who's the most common person to get a foreign body airway obstruction? Kids, especially toddlers. They're running around, they're little, they grab something. What's the first thing they do when they grab something? Goes right in the mouth. They don't know that it's too big or it's just the right size to go down. Did I tell you guys my PTSD story of airway obstruction? So we got a respiratory distress call, went on a call. There was a 12-year-old girl in the living room, unresponsive, cyanotic. Parents said they came in and found her this way. They didn't know what was wrong. We started bagging her. Couldn't bag her. Repositioned her airway. Couldn't bag her. Put an oral airway in. Couldn't bag her. This is before we even had nasal airways. Couldn't bag her, so I got the laryngoscope, looked down there. I couldn't identify anything. Pulled the laryngoscope out, bagged her, repositioned her head, looked again. I couldn't see anything. My partner looked. He couldn't see anything. We grabbed her and hauled ass to the hospital. The ED doc, he looked in there. He couldn't identify anything. This is before we did crikes in the field. They criked her, ventilated her. She did fine as far as ventilation. She was ventilating really well, but she was in cardiac arrest. We've been doing compressions on her for a while. she died. The medical examiner's office found a pink piece of plastic about that big around lodged in her upper airway. And what she had been doing was she'd been blowing up balloons for a sibling's birthday party. She blew up this pink balloon and somehow it popped and she inhaled a piece of that balloon. Yeah, PTSD moment. Sad deal. You know, wasn't anything we could do. Even the ED doc didn't recognize anything. So, yeah, upper airway obstructions. Try and get them out. Heimlich, chest thrusts on little kids, back blows. My oldest daughter, when she was a toddler, my mother-in-law gave her some carrots. Next thing I knew, there was screaming upstairs, and I went upstairs. And my ex-wife handed me our daughter and said, "Fix her." She was choking, she was cyanotic. I just flipped her over, did the 5 back blows, knocked it right out. But so it works. Heart failure. A lot of times, this is a problem with the geriatric population, or it can be a genetic problem with kids, just born with some kind of heart problem. A lot of times, it's caused by hypertension and coronary artery disease. Those are the 2 biggest risk factors for heart failure. A lot of times these people have respiratory distress, especially with exertion, and it doesn't even have to be a lot of exertion. People my age and Kurt's age, you know, walking up the stairs sometimes. Right, Kurt? We don't have heart failure, but anyway, a lot of times it'll come on suddenly, especially people that have these pre-existing conditions. Just be aware of it, because there's not a lot we can do for it in the field again. Just get them to the hospital. And O2, a lot of times these people have pulmonary edema, and they will have dependent edema, because that heart is not pumping right, and so it's not circulating that blood as well as it should. Cardiac asthma is basically wet lungs, also related to pulmonary edema. Dry lungs are the COPD. Sometimes breath sounds are confusing with these people. You'll hear different things. You'll hear crackling, you'll hear wheezing. Maybe you won't even be able to hear sounds really well, just because they're not perfusing well, they're not ventilating well. Remember to treat the patient. Don't treat the breath sounds, treat the patient. Let's take a 2-minute break.
Johnny,
You?
you guys didn't know that John's birthday is today.
Happy birthday, John.
Happy birthday, John.
I come to work.
I'm an old man.
How many you got left?
I don't know how many I've got left. The more I do this, the less I have.
Just give them away.
Right? Yeah, I gotta run home and look in the mail. My Medicare card should be in the mail.
Hey, do you have a schedule on the ride-alongs in your office?
Yeah, I think yeah,
What's happening? I'm tired. What's happening? What shift are you on? You just failed the rip for minutes? How many hours did you run? It's like your only job is just to study right now.
Who'd you do the advance through?
Moved to Utah, but I don't know, I did their class and I was honestly pretty, felt like I wasted $1,200 for sure. 'Cause it was, I don't know. Like you'd ask, the instructors that they have there have actually never worked in the field. They have like certification and so on, now they just teach. But if you ever ask them anything, they're just like, well, I can get a YouTube video for you, like, whatever. I'll just go read this shit at home, like, and so.
I think that's one of our paid calls going there. I think that's who she's doing it through. She said the same thing. She said, you'll ask questions like, oh, you don't need to know that for the test.
Yeah. And then you actually see it on your test, you're like,
Thank you, Steve.
yeah, thanks assholes. No, it was just kind of, I've been pretty disappointed in how that went.
What school?
Utah. Yeah, but at the time, they were the only ones that were having the class when I needed to take it,
Yeah.
so I was like, oh.
Did they pay for it, or did they make you?
I paid for it, so. But they didn't, I guess, so I'm the first one at South Jordan that's had to do the national registry stuff for the advanced. And so they were all kinda like, well, maybe you'll just go take the state test, be done with it, you know, and then all the national stuff came out with it, and they're like, oh. So they're trying to figure it all out too, but they were like, well, it sucks that you're kind of the guinea pig for this, like, kind of, cause they're like, none of us know what to do for you, but, you know. I don't know, the initial, cause you have like 135 questions, but 35 of those questions are like the dummy questions. And they're like, or they're like the test, I don't know. They call them filler questions is what they are, but they don't actually count towards your test, but they're like the most off the wall, like, just there to stress you out, yeah.
Why?
I don't know. But like I had a ton of questions about like cancer and stuff, like I had like, yeah, like super weird stuff. I was just like, okay. I had like insulin dosages, I had nitrous oxide dosages, like shit you've never even heard of, and I was just like, sure.
What?
Yeah, because they pull from curriculum all over the country, so it's like, you can't even really study from them.
Insulin though, like.
Yeah, I was like, I know it's in units, so, but then you look at all the answers and all of them are in units, and you're like, C, sure.
Yeah.
Yeah. But, yeah, I just had some issues.
What do you have to pass with?
So they don't even give you like a percentage grade. It's like, you have a above passing, near passing, or below passing, is what it gives you on all your topics in it. But I think you have to have like the 95% confidence score or whatever, like, so the two of the answers are in the confidence area, and I guess if you pick one of those two, it counts as the right question. So.
So there's two right answers?
Yeah, so there's like two right answers, but it's, I don't know, it's kinda weird.
Well, it's dumb too, cause then you're like sitting there second guessing yourself and you might waste a bunch of time on the question.
Yeah, but the frustrating thing is like, the near passing is, like the near passing category means you got from like 90 to 94% on that area. And so so I took it 3 times, and every time I passed everything except for one, and it was the near passing, so I was in like 5% of passing the dumb thing. It was like, what?
I do any study guides or anything?
Yeah, so I've been,
App or something?
so I got the ones that Kevin Burge got was like the AEMT pass stuff through that living for you. I've been doing that. I got medic tests, which one of the guys at South Jordan used for it was doing it through paramedic school, and that's been really nice because it has like the National Registry like simulator. And so, because you have, I think it's like 160 something minutes to do the whole test, and so.
How was the one Captain Bruce?
It's been pretty good.
Is that the LC?
The LC ready or whatever it is.
I've got it, I just haven't gone on there yet.
It's got some kids.
It's like $25, right, $30, something like that.
The EMT pass app is, I think the AMT review or whatever it is, I wanna say that's only like 11. It's not much.
Right.
One of those.
You get both
That's
of them,
for,
right?
that CLS
I
test.
just got the AEMT and EMT.
Yeah, I think for the both of them.
Where's
So I'm gonna
CLS
do that
test?
tonight.
Okay. Has everybody else done the ACLS test? I think everybody else has.
Yeah, I'm doing mine tonight.
Okay.
Once I get home, we can do it.
It's
Okay.
messy, we did it as a group.
Come on, prepared again, Murphy.
I did, I
Yesterday,
got a lot of
one
pens.
these things.
Oh.
My captain was like, I wanna try it.
Right.
'Cause he's been a medic for like 15 years.
Oh, I didn't think it could.
He definitely failed at like.
I just
Now I'm
found one.
sad.
Yeah.
He's just like,
Right.
this is bullshit.
I don't get why they're trying to do that, why are you making?
It was kind of weird, but he was so big, like he pounded all freaking day. He's like, I can't believe you passed the day EMT test.
See, that doesn't give me a fun confidence when I would take the test.
It's stupid. Like, I know some guys that will go in there and pass it on their first time. And then I've got like, so the thing with the class that I took, not one person from my class has passed it.
Oh, crap, really?
It's
Yeah.
bodes well
It's
for
great
this.
voter
That's a pretty
confidence.
crappy,
Yeah, like I already talked to one of the guys that works at South Jordan, that is one of the like instructors there, but he only teaches the basic classes. And I told him about that, he's like, well, he's like, it looks like we have some fixing to do there. I was like, yeah, I was like, I kinda want my money back.
Not very voter
But,
confidence.
no, I guess,
Okay,
they're working on it.
let's get going so we get through this stuff.
Pain in the ass.
Yeah.
There's a lot of material to cover here, and we have a limited amount of time, so I apologize, but we'll get through it.
Thank you. Do you need everybody to do this?
No, yeah. Oh,
Well, I need it.
Brandon, have Brandon fill it out. I just can't put your score in yet until you.
Is this the ones that weren't in class?
I think so.
Yeah, and then whoever, you should have had been assigned.
I'm taking mine tonight.
Okay.
So I've got it online.
Alright, you did yours online and figured that
Oh,
out.
did you do yours on
I
LMS?
did it on LMS.
Okay,
Fill that out.
so, yeah, fill that out. Okay, patient assessment. What's your primary responsibility? Okay? Whose safety? Yours. You are number one. Always remember that, never forget that. Who's number two?
Partner.
Yep, your crew. Partner or your crew. Who's number three?
Bystanders.
Yeah, everybody else. They just fall into the mix somewhere. Why are you number one? What if something happens to you? Who's gonna take care of you?
Now we have two emergencies.
Hopefully your crew will be taking care of you. And nobody will be taking care of the patient. Right? Okay. So, quick story. When I was working in Los Angeles, we were transporting a PCP overdose. He started to beat my partner up in the back of the ambulance. So I stopped in the middle of the street, ran around and opened the doors to save my partner. Next thing I remember is I was in the street and I was thinking, I gotta get out of the street. I don't know why I'm in the street. I'm gonna get run over, and then I hear screeching tires. And I thought, well, this is it. I'm gonna get run over. And then I hear this. And this pair of black boots goes by my head. And that's the last thing I remember about that, till I woke up in the emergency room. What had happened was I got in the back of the ambulance to help my partner, and this guy just came up and drilled me. I went right out the back of the ambulance. Well, the screeching tire and that I heard was an LAPD motor officer who was about a block behind us. He came and talked to me in the hospital later. He said, yeah, he said, I couldn't figure out what the hell this RA was doing stopping in the middle of my street and blocking traffic. And he said, you ran around the back, you jumped in, the next thing you were like this in the middle of the air. And he says, I ran up there and I took one look at you and you were doing the guppy breathing. But he says, so you were breathing, I had to go help your partner. So Yeah, scene safety. I wasn't very safe. I was just jumping in, not paying attention to what I was doing. Ended up with a concussion, ended up in the hospital. Yeah. I got all we could spend the whole time telling stories if you want to. I can tell a lot of stories. So, scene safety, you're number one. Look at the conditions around you, kind of find out what's going on. How many patients are there? Think about that. As soon as you walk in, kind of figure out, try to figure out what's going on. Is your patient awake? Are they talking? Are they breathing? How critical is your patient? You can determine that as you're walking in, right? A lot of times you can tell as soon as you get in there, kind of how serious things are. Take a look at your patient. You don't even have to touch them or talk to them. Look at them. Look at their facial expression. Look at their lips. Are they cyanotic? Are they having trouble breathing? Are they clutching their chest? Are they bleeding? You know, is there a gun laying next to them on the floor? Lots of things that you can take in as you approach the patient and approach a scene. As you walk in, you can hear people if they're coughing or severe respiratory distress, stridor, croup, all that kind of stuff that we've talked about. First thing that you want to do is get a general impression of your patient, kind of what is going on. One of the things you need to remember is when you get a call and you get dispatched, dispatch gives you a number and a letter and a basic description of what's going on. Sometimes en route to the scene, you may be getting a whole bunch of information. What do you need to know? Does the stuff that dispatch tells you really mean anything?
Usually.
Okay.
Sometimes.
The thing of it is, what I'm trying to get at is keep an open mind. Don't get tunnel vision. Okay, you need to know, are you going to a traffic accident? So if you're going to a traffic accident, what kind of stuff do you need? If you're going to a medical call, what kind of stuff do you need? If you're going to an assault or a shooting or a stabbing, what kind of stuff do you need? You need to think generally. It's not dispatch's fault. I'm not ragging on dispatch, because where are they getting their information? Callers. And who is usually the caller?
Some guy driving by in a car.
A lay person. They may or may not even know the patient. They may or may not even really know what's going on. I've got a really good story about that. If we have time, I'll tell it to you. But don't rely on what dispatch tells you. You are the one that has to figure out what's going on. Okay? So, form a general opinion. Determine right away if this is a life and death situation or if you need to start doing something right away. Okay? Identify life-threatening problems with your patient. Are they breathing? Are they responsive? Are they bleeding? Do they have a lot of blood around them? Do you have to stop bleeding right away? Are they really shocky? Do they look really bad? Are they having severe respiratory distress? Do you have to start oxygen on them right away? Is somebody sitting on a toilet with a baby in the toilet that you're going to have to take care of right away? You got to figure out what's going on and take care of the priorities as soon as you can. A lot of times it's just being aware of what's going on. We talked a little bit about breath sounds. So, like I told you before, every time you evaluate a patient, listen to breath sounds. Auscultate with a stethoscope over the anterior chest. So, whoops. Listen to the upper chest, right and left, and the lower chest, right and left. These markings are not exact. You'll kind of get used to being able to listen to breath sounds. Also listen to the back. Sometimes you can hear better on the back than you can in the front. So auscultate the patient. Make sure when you auscultate, if you can, have them sit up so that you can listen to both anterior and posterior.
Top, is it doing more on the sides or is it right under?
No, just in the front.
Okay.
Yeah. You can listen to the sides if you want, but it won't really tell you any more than listening to the front and the back. Are the breath sounds normal or abnormal? How do you know? Practice, 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 practice. And like I say, go on the internet and just Google breath sounds. You'll get a gazillion hits. And you can listen to different breath sounds on the internet. Pretty interesting. I'm not going to go over to what they all sound like because a lot of them are pretty self-explanatory. The big ones are stridor and wheezing that you can hear audibly when you come in. If you start hearing that, your patient's in trouble and you've got to figure out what's going on. When you're talking to people, remember to talk to people in layman's terms. Don't use medical terms with people. Use plain language when you're talking to people. Tell them what you're going to do. I'm going to listen to you breathe. Or I'm going to put some patches, these stickers on you so that we can hook you up to our cardiac monitor. With kids, don't ask their permission. Don't ask a kid if it's okay if you do something. Because 99% of the time, what's a kid going to say?
No.
No. Then what do? Well, you do it anyway. So then what? Yeah. Now you've got a kid that's pissed off and a kid that doesn't trust you. No matter what you say from then on, that kid is not going to trust you. So let mom or dad hold the kid, or somebody familiar with the kid, let them hold the kid. You can do things to distract kids. Have mom or dad distract them, have your partner distract them to do things. Tell the child what you're going to do. Don't ask their permission. They may say no anyway, but if you haven't asked their permission, you're a lot better off. If you're going to do something that's going to hurt them, tell them. If you're going to start an IV on them or give them an injection, tell them. Yeah, we have to do this. I know it's going to hurt. I got a whole nother. So we had this kid. It was an autoped. Kid had a fractured femur. He's like a 10-year-old kid. He was from a foreign country over in African region somewhere. He'd been here for a couple of years. I was going to start an IV on him. So I told him, I'm going to give you a shot in your arm. It's going to hurt. It's only going to hurt for a minute. It feels like a bee sting. Well, this kid is from an area, and I didn't even think about it until after the situation. He immediately starts screaming and panicking. Bees! Bees! You got bees! Well, he's from a nation where they have the African killer bees. And bees have killed people. He thought we were going to kill him. So, kind of be careful what you say. You know, took us quite a while to calm this kid down. By then, I'd already gotten the IV started. He was more afraid of bees than he was of me sticking a needle in his arm. Talk to the family, talk to bystanders, just kind of get a general impression on what happened. Make sure that you get a good history on the patient. Talk about previous medical problems, how long this particular problem that they're involved in has been going on. Talk about medications, especially ask about allergies. Make sure that you ask about allergies. Now, a caveat to this is, I don't know how many times I've talked to a patient in the field, ask them if they're taking any medications. Nope, I really don't take any medications. Okay, do you have any medical problems? Do you see a doctor regularly? No, not really. Take them in the ED. The nurse starts talking to them. Do you take any medications? Oh yeah, I take this, and this. Really? Really? So sometimes you got to be a detective and draw things out of people. You know, get used to medications. Get used to the names of common medications and what they're for. A lot of times people, if you ask them, do you have any medical problems? They'll say no. Do you take any medications? Well, yeah, I take a few. What are they? Or your partner goes and finds them. And they're taking lisinopril, and they're taking cardizem, and they're taking Lipitor, and you're going, well, okay, you're taking blood pressure medication, and this heart medication. Well, yeah, but
I don't have a medical problem when they're taking all this medication.
Right. The medications fix me. I don't have high blood pressure anymore. So that happens. OPQRST. Everybody know what that is? Okay. Whoops. So onset, provocation, quality, radiation, severity, and time. So when did it start? What makes it worse or what makes it better? What's it feel like? Does it go anywhere? How bad is it? Scale of 1 to 10. And how long have you had it? Or has this happened to you before? So just remember those. Chronic problems. We've already kind of talked about chronic problems. Probably the most common one that you're going to run into is COPD. Asthma is another one. You may have to do a little bit more in-depth assessment on the patient to find out what's going on or figure out what you're going to do. Like we talked about before, identify and treat any life-threatening problems. Just look at your patient, pay attention to them. Listen to what your patient is telling you, and listen to your patient, how they're breathing and what they're doing. Secondary assessment is after you've figured out that they don't have a life-threatening problem that you have to take care of right away. What I like to do when I assess a patient is I'll walk in and get a general impression right away. It takes 2 seconds. And then I'll walk up to the patient, introduce myself, ask them what their name is, and I just reach over and I feel their wrist. I grab their wrist and feel their pulse. What kind of information am I getting there?
Heart rate, quality, skin color, temperature.
Yep, exactly. Does it matter if the heart rate is 70 or 90?
Maybe making sure it's there and it's regular.
Yeah, right. Checking to see if it's regular. What about if it's 180? I mean, it's going really fast. Yeah. Okay, so I know that it's going really fast. What if it's going really slow? Yeah, okay, it's going really slow. So is that going to affect my assessment a little bit? Yeah, sure. There's a problem. I need to know about it. Irregular heartbeat. Yeah, okay. Figure out why it's irregular. Or you can't get a radial pulse. What if you can't get a radial pulse? If I can't get a radial pulse, I'll switch to the other arm real quick. Check that arm. Sometimes, for some reason, people have surgery and they may not have a radial artery in that arm. Not very common, but it does happen. Check the other arm. See if they got a radial pulse in that arm. If they don't, start really paying attention to the patient, figuring out why they don't have a radial pulse. If they don't have a radial pulse, where do you go? You can go to carotid, yeah, or brachial, either one. If you have an unresponsive patient, you can check a femoral pulse real quick. That'll kind of give you an idea of how well they're perfusing. Okay, so your secondary assessment, this is when you're going to be listening to breath sounds. You're going to be getting your vital signs here, going into history and sample, finding out what's going on. Once you've kind of figured out what's going on and you've started treating your patient, what do we need to do? Reassess them. Okay? If you've done any intervention at all, oxygen, started an IV, whatever, you need to constantly reassess this patient. If you've given them medications, is the medication working? Is it not working? Did they have an adverse reaction to the medication? Reassess, reassess, reassess. Now, does that mean you have to take vital signs every 2 minutes? No. But constantly look at your patient, keep talking to your patient, keep figuring out how their level of consciousness is, and see how they're doing. You can take vital signs every 10 minutes or so, unless you have a critical patient. If you have a critical patient, recheck their vital signs every 5 minutes. So, some of the things that we're going to do for patients. Probably the biggest thing and the first thing we're going to be doing is giving them oxygen. We want to get their SATs above 94%. You want to keep their SATs between 94 and 99. Once you get to 100, you don't really know if they're at 100% or if you're oversaturating. You can oversaturate. It causes damage to the alveoli is what it does. So try and keep them between 94 and 99%. Keep talking to your patient. Reassure them the whole time. If you have a patient that's in severe respiratory distress or having chest pain or whatever, don't get them up and make them walk out to your gurney that's out at the front door. Bring the gurney in. At the most, have them stand up and sit down on the stretcher. If they're in real distress, pick them up and put them on the stretcher. It's just part of our job, and it's just good patient care. Oxygen, we kind of talked about it. So what do we usually use to give oxygen? Yeah, we usually start out with a nasal cannula. And how many liters are we usually given? Yeah, 2, 4, you can go up to 6. If you're giving them 6 liters of nasal O2 and their SATs are still 88, switch them to a non-rebreather mask. Yeah. And look for other signs or other reasons why their SATs might be a little bit low. Bronchodilators. What's the most common bronchodilator that we use? Albuterol. Okay. We've already talked about albuterol and how we use it. It's really not going to do much for people with pneumonia or pulmonary edema or CHF. So just remember when to use it. So yeah, we talked about bronchodilators. Nebulizers, basically just used for asthma. The paramedics may administer epinephrine through the nebulizer, so they may ask you to help with that. Remember, when you're using a nebulizer, 6 liters a minute. That's your flow rate. That's one of the most common problems with a nebulizer is turn it up to 15 liters per minute. It's not going to work real well. We talked about MDIs. Usually, we don't carry these. Most of the time, if you use them, it's because you're using the one that the patient has. And the biggest problem with this is usually by the time they call us, they've already used this thing 3 times or 4 times. Or they've used it and now they're out of it. And it's not doing any good. So don't use an MDI if it's not prescribed for that patient. MDIs are specifically prescribed to people for specific problems. So if you have a kid that's having respiratory distress, don't let parents tell you, oh, older brother or younger brother or sister or whatever has an inhaler. Let's try that. Don't do that. Okay? Dry powder inhalers, those are mostly used by respiratory therapists. We don't have to use them. Talking about fluid a little bit, just be judicious in, after you've started an IV, make sure that you keep an eye on that flow rate, especially if you've got somebody that's got pulmonary edema or CHF, and they already have a fluid overload problem. You don't want to give them too much fluid and overload them. So if you're starting an IV on somebody that's got wet lungs, start a 500 cc bag. So most medical problems or patients that are not hypotensive that you want to give fluids to, do a 500 bag. If you've got a trauma victim or you've got a hypotensive patient for whatever reason that you want to give a lot of fluids to, hang a liter bag. Pretty simple.
Would that be a reason not to give fluid to somebody with pneumonia?
You can give fluids to them, you just have to be judicious. People with pneumonia, they can get hypotensive because they got a lot of fluid that's coming off of their systemic system, and so they may be a little bit dehydrated. What you're trying to prevent is the fluid overload in the lungs themselves, and you're trying to prevent the problem with the gas exchange in the alveoli. So that's the biggest problem with the fluid overload. Support or assist ventilation. Narcotic overdoses. What do we usually have to do with them? We have to bag them. Okay. Are we going to intubate them?
They got Narcan on board.
Yeah. Yeah, unless you've given them a couple doses of Narcan and there may be something else going on, yeah, don't intubate them. In fact, with most narcotic overdoses or suspected narcotic overdoses, I don't even put oropharyngeal airways in. Drop a nasal in. Mostly because if they have an oropharyngeal airway in them and they give them Narcan and they wake up right away, they start gagging on that thing and then they puke. A lot of times they're going to puke anyway. I'm a big fan of IM Narcan. It takes a little bit longer to bring them around, but they come around a little bit slower. Give IV Narcan and pretty quick all of a sudden they're waking up fighting you and puking and got all kinds of problems. IM or IN, either one everybody okay with that? Anybody have any questions or problems with the 1 and 2 person bag valve mask and getting good seal and stuff? Really important to get that good seal if you're bagging somebody. Probably the most important thing that you can do. CPAP, we talked a little bit about it. Some people wear these at night all the time. We have firefighters that use them in the fire station. All it does is it creates a continuous pressure inside the lungs to keep those alveoli open. Sometimes we use it with CHF to kind of push that fluid out of the alveoli. You're creating that pressure inside the lungs, inside the alveoli to push it out. If the paramedics are putting CPAP on somebody, be familiar with it and how to put it on. I think Dan showed you guys how to put it on. And the one thing about this is you're going to have to talk to the patient, and because a lot of people that are using this, it feels different. They feel like they're not getting enough air and oxygen, and they are. The only contraindication of the CPAP is if you have somebody that's unresponsive or not alert. So, BiPAP is a little bit different. We don't use this in the field, but I'll tell you what it is real quick. What it does is it creates a pressure going in, and then it literally creates a negative pressure coming out, so it'll pull air out also. It's kind of like a ventilator, basically what it is. It does the in and out, does a two-throw. Upper and lower airway diseases, we have kind of talked about these a lot. Main thing is listen to their breath sounds, see what they're doing. If they're wheezing, it's a sign of a lower airway problem, and you can probably use albuterol on them, or at least try albuterol, see if that helps. Put the patient in a position of comfort. Let them sit however they want, however is comfortable for them. Whatever is going to make it easier for them to breathe is probably the most important thing you can do for them. Acute pulmonary edema, there's not a lot we can do in the field. We're just going to give them oxygen. If they really start having problems breathing, you might ventilate them. Get them to the hospital. We used to give Lasix in the field, and we used to give morphine for pulmonary edema. We don't do a lot of that anymore. So get them to the hospital. Aspiration of any kind, you've got to try and fix it, especially if it's an upper airway problem. People that aspirate things, especially if they have a complete obstruction, pretty high mortality rate for complete obstruction. So just remember what you need to do. Remember your BLS skills and your basic healthcare skills as far as how to correct an obstruction. Suctioning. We'll talk about suctioning for just a second. What do we have that we suction with? What are the two basic devices that we use to suction? Yonker and a flexible catheter. Okay. How far do you put that yonker into somebody's mouth?
As far as you can see.
Not even that far. Don't put it past the teeth. Okay? General rule. Otherwise, you run the risk of shoving it down and either creating a problem in the airway or lacerating the back of their throat or tearing off their uvula or a tonsil or something. So be very careful with that yonker. It's rigid. It's rigid for a reason, but it can also cause problems. How long do you suction somebody for?
No more than 15 on an adult.
Yeah, 15 seconds at the most. A good rule is when you stick that in there to suction them, start holding your breath. If you need to take a breath, so does that patient. Get that suction device out. When you're suctioning, depending on the device that you're using, if it's got a port to control the suction, suction coming out, not going in. So when you're putting the device in, when you get it to the point where you want to get it to start suctioning, that's where you start suctioning and pull the device out. Okay? COPD we talked a lot about already. These people don't like to lay down. They're going to want to be sitting up. Asthma. If we have given them nebulized treatments and they're still having a lot of trouble breathing, be prepared to assist them. Be prepared to bag these people. Because especially kids are going to get really tired really quick. If you have to bag them, remember controlled breaths with them. Sometimes you'll intersperse breaths in between them, or you'll just assist their breathing. Anaphylaxis, find out what they're allergic to. Find out what caused the problem. Watch their airway, especially if they have a true anaphylactic reaction. The biggest problem is their airway swelling up and causing hypoxia. Spontaneous pneumo, we already talked about that. Pleural effusion, pulmonary embolus. Big thing about pulmonary embolus is a lot of these people will go into cardiac arrest. So if you're suspicious at all about a pulmonary embolus, keep a close eye on them. High flow O2. Start moving towards the hospital and be prepared to do CPR on them. Hyperventilation, we already talked about. Most common cause is some kind of stress-induced problem that person's had a stressful event and just started breathing too fast. Airway obstruction we've kind of killed. Environmental and industrial exposures. What's the biggest problem with this? Number one.
Your safety.
Number one. Okay, your safety. If you respond to an industrial building or an industrial complex of some kind, and somebody meets you out in front and says, hey, we don't know if it happened, but 3 of our workers in here are down. What are you going to do? You're going to start asking questions real quick. Start looking for placards. Don't be running into a situation that's going to get you in trouble. Be really careful about that. We had an incident several years ago up in North Salt Lake at a place that did tanning. They were tanning hides. And one of the guys got overcome by fumes and fell into a vat. Coworker came in, and because he hadn't heard from the guy for a while, saw his legs sticking out of the vat. He ran in to try and help this guy and yelled for help. He went in the vat. Another guy came in. He didn't even make it to the vat. He went down. 4th guy got to the door and went, this doesn't look good. I'm not going in. So 2 of the guys died. The guy that went down before he got to the vat, we resuscitated him, and he ended up with some real long-term problems. And the 4th guy, obviously, he survived because he was smart enough not to be running in there. So be careful about your situation. This is situational awareness. Okay? All right. Bronchiolitis we talked about, RSV, these are wintertime diseases. Little kids, real prone to this kind of stuff. And we're gonna start seeing it here in probably about a month. November through about the 1st of March is when we start having a lot of problems with bronchiolitis and RSV. Croup is kind of the same way, it's a seasonal disease. Epiglottitis, pneumonia, we've already talked about them, what to do for them. Pertussis, same thing. Biggest thing I can warn you about this is make sure that your vaccinations are up to date, so that if you do happen to deal with somebody with pertussis, you don't get it. So make sure that your vaccinations are up to date. We've kind of beat all this stuff to death already. Airway, 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 airway. Okay? That's just basically what you got to remember. Occasionally you're going to run into kids with trachs. The biggest problem with these is a lot of times they can get mucus plugs in their trach and they need to be suctioned. Talk to the caregiver. 99% of the time the caregiver knows how to take care of this problem. And they may just be asking for assistance. Sometimes they've already tried to take care of the problem and can't take care of the problem, so they've called you and you're already behind the 8 ball when you get there. You've got a panicked caregiver, you've got a kid that's in severe distress, and usually these kids have a lot of congenital problems anyway. So they've got a trach. Sometimes the trach may already be out. You just have to do what you can do to correct the problem. A lot of times, like I say, it's a mucus plug. If that trachea is completely plugged and you can't unplug it, take it out. They'll have a stoma that they can still breathe through. You can deliver oxygen through that. You can even bag through a stoma. It's really difficult, but you can bag through a stoma. If you're going to bag them, use a size smaller mask than you would normally use for that patient. These are usually pretty scary situations. These kids with trachs that get plugged up. A lot of them are small anyway, but they look a lot younger than they usually are, and they have a lot of problems. Epidemics, pandemics, we're probably going to know about them. Usually healthcare workers are the first people that get notified about this kind of stuff. Just make sure that all of your vaccinations are up to date, and do whatever the CDC recommends that we do to protect yourselves. We got to remember to protect ourselves. N95 masks. If you have any inclination that a person that you're dealing with has some kind of communicable disease, and they're coughing a lot or spitting a lot or whatever, double mask. What I mean by that is you put a mask on and you put a mask on the patient. Everybody else wears masks that's having contact with that patient. Really important, especially getting up to this time of year when we start having a lot more respiratory problems. Remember those N95 masks. Flu season's coming up. I know a lot of people have differing ideas about flu shots, and some people say they get sick every time they get them. I don't know. It's a personal thing. But I encourage everybody to get a flu shot. Because I get one, and I don't want you not getting a flu shot and getting the flu, then you're at risk of infecting everybody else. So, PPE, kind of what we just talked about. Hand washing, really important. Wash your hands. Everybody know how to wash your hands? Warm water, soap, wash your hands thoroughly for 20 seconds. How long is 20 seconds? Say the alphabet. That's what I do. I'm washing my hands. A, B, C, D, E, F, G. Okay?
You have to include the next time see the D part?
Yeah. Yeah. Only if there's somebody in the bathroom.
Okay.
Especially if they're on the toilet.
Alright.
Yeah. Okay. Any questions? Sorry, we went through this pretty quick. This is usually a half-day lecture, so. But you've already had a lot of it, so a lot of it should be familiar to you. Just remember, you're number one, airway, get a general impression, figure out what's going on, is it life-threatening or not? What can you do first to kind of solve the problem? Oxygen is your friend. Oxygen usually is not going to hurt somebody. And do a good assessment. Reassess, 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 reassess. Okay? All right. Take a break. And then I'm going to turn you over to Kurt. He's really going to get you.
What do you got for us?
Today we have diabetes and hematology.
Yeah, baby.
Okay, cool.
Oh, okay.
Figure out what else we need.
Good. So
Like shoulder length?
Bryce.
In my mind, there's not. Is the only one that, right?
Breast, right?
You know, that,
Rouse.
like,
What do you call that?
professional.
Right.
Oh, yeah. Okay, all right.
Yeah, yeah. A little bit of sugar to get you going.
I probably don't need it more.
I think they're growing it outside.
Doesn't
Never
seem-
have to.
Doesn't seem to be working on it.
Do you want
From like most angles, you're not gonna hear.
early days?
Just slamming the whole pot this morning.
Doesn't matter.
So, the way that you got some more
Okay.
CME stuff, right?
How did she go?
She will be.
Rob already have it, but that's okay.
Yep.
I'll show you, 16 hours
This is too long.
It is. I've got some, I didn't bring it with me at all. I'll bring it in and, have you look at it. I made up like a little.
Cause I agree.
Like this.
Okay.
All this like kind of this.
Oh.
I worked out 6 hours while I was student, so. He told me, your only job is machine press. So, he said,
Do you use that stuff?
over the months of the years, he's been a paramedic for less than 18 years. So Josh Brown is my mentor at the practice movies, how it's work.
I like it. He's a good guy. He's cocky as hell. But I love it.
I like Josh Brown. He's such a good guy. He always gives a shit for his mates and boys. Every time he walks in, he's like, shut up, you guys.
Alright, so how much did that t-shirt end up costing you?
This one?
Yeah.
I think this one was like 21.
21 bucks? Oh, for the long sleeve.
For long sleeve. Short,
21?
yeah, short sleeve is cheaper.
Unless they sent out ones.
Is that one for pocket?
Pen pocket. Oh, look. Okay, for all sorts of accessories.
I think that's about right. Unless they sent out was.
Do they even have any of these sweatshirts?
The quarter zips?
Yeah.
Yeah, I went and bought one.
And hats? Is that a new hat too?
This is not one of the new hats. The new hats are the mesh.
Okay.
They're the mesh. And they did have some of those there. They're a little tight.
Problem is, last year I spent like, I don't know, $300 getting new shit.
Now it's no
Now I gotta.
But you got a whole year. You got a whole year. You don't have to go right away, right?
Well, I know you have a whole year, but it's still. So now I'm just like, my wife's like, I need a t-shirt. Well, here's one. Sleep in this. There you go. It's long sleeve. It's funny.
They made meetings.
What?
Meetings.
No, yeah, we just talked about that today.
Okay.
You should know.
They're gonna get all of that, not mesh.
No.
What do you think about the mesh? I thought.
Yeah. I guess, I talked to Nate, he had said that whoever he had talked to said they wanted to match. And I said, I haven't run into anybody yet who's been pro match. Yeah, that's essentially smart match. So, but it's not, now that it's there, it won't change,
They can't change that. They can't say selfies and start making this.
So the reason that we're not gonna change it is just more opening the floodgates as far as like everybody wanting everything to change right now. So what we'll end up doing.
We're sticking with the crappy version.
I know. So I asked, okay, so well, what's our timeline then for evaluating? We have, there's a problem. No, like, we're gonna be able to change it right now. So probably in 6 months is when we'll be able to talk about it. So, worst case, it would take like the next 1 month. So, gotta play the long game there. That's what we're doing. What do you?
I don't know.
Let's scroll back up.
Okay. Going back. Alright, so last time I did my my lecture, first off, I just need to kind of tell you guys a little bit something. Sometimes you'll wonder where I'm going with my story, and you're like, man, I don't know, I'm feeling a little embarrassed right now. So has everyone seen that show, Modern Family?
Yeah.
Okay, so a modern family, I'm the dad, but I didn't marry a Colombian chick, okay? So my family is just like that family, Modern Family, okay?
Okay.
So if you take a look at my family there, I've got me, and then my oldest son, he comes from my first wife, and he's half black. Even though you can't tell, he looks like a Puerto Rican. And then my second son, he's from my marriage to my first wife, and he's half black, but he's also gay. And then I have my third son, and he's like a prophet of the Lord. He's Mormon, okay? Really Mormon. And then my daughter, she's more like me than anyone else in this world. She's cool as hell. And then my youngest daughter, I adopted her from Philadelphia, and I've had her ever since. She's been 10 days old. So, and then my wife now has two kids, a daughter and a son. So we have 7 between us now. And I'm honestly, I'm feeling kind of punchy today because the oldest daughter of hers, and I hate step names or whatever, but so I'm gonna call her my daughter. She got hit by a car in Provo last night. Her friend didn't do so well. She's got a broken pelvis and broke her humerus head off in her arm. And Molly, she got a cracked clavicle and lots of bruising. Hit her head. She's 21, and guy just didn't see him. I think she got the headlight more than the main part of the car. So it's been a long night. Anyway, but like I said, sometimes for me, like even when I was adopting my daughter, I always called my kids mulatto. Everyone heard that term before? Well, apparently that's a slaver term. Because it's it's when you breed a donkey and a horse, so we get a mule, right? But they're halves. So what do you call them?
Is
And
that
then
an official term?
and then my son here, he married a little Dominican girl, and Dominicans speak Spanish. If you ever been Dominican, they all think they're Spain Spanish. No, they're black. They're as black as they get, right? So now my grandsons, he's got 2. They're little brown kids too. And then my gay son adopted a little girl, and she's Latino, right? So my family has like a big rainbow going through it, right? And so I hope that I don't ever offend you when I talk. And I sometimes forget that you don't know my background. So I just kind of want to clear that up real quick. I know, just one of those things. It's really important that you don't get offended by the shit that I do. Okay, let's go with escape from that.
Like a wedding picture?
Yeah. So we just got married.
Can you see a better picture? It's closer up maybe?
Oh yeah, we wanna see your wedding picture for sure.
You do? Really? I'll show it at the end of class. We had a good time. Alright, we good? Alright. So, we're going to talk about diabetes today, and we're going to talk about some hematology, or what is hematology? What do you think that's about? Blood, okay? So, okay, this is something we go on a lot, and you have been killed by death by PowerPoint today, so we're just going to kind of go over and talk about a couple things, and then, because I really think that most of you probably have a handle on what diabetes is, okay? And we're going to go more over treatment modalities and how we would deal with that in the field. All right. So, just as a quick thing, we'll talk about endocrine disorders, diabetics and diabetes is part of that. We'll go over the anatomy and physiology.
and we'll talk about sickle cell anemia and the hematology and clotting disorders and why those are even important to us in the pre-hospital setting, okay? So when we look at our endocrine, it really, the thing that as an EMT, you were learning about, you know, what can I do to help? How can I take vital signs? How am I going to do a OPQRST and sample? But now you're kind of learning what's happening at the cellular level. You're going deep into a body system and what's going on. And so when we talk about endocrine problems, we are talking about things that are happening at the cell and the organs and how and what organs are affecting those cells and body functions. When we talk about the blood emergencies, they're rare, but the biggest thing is we just have to think about it when we're doing our assessment on our patients. And again, we'll talk more about that in a minute. So when we look at our endocrine system, there's a whole bunch of glands. So we have our, and not a lot, we can't do a ton about much of the, excuse me, the endocrine system. We don't have a lot in our toolbox to fix it, right? The only thing we have, or we deal with mostly, is the diabetes problems, but we've got our pituitaries, our thyroids, excuse me, our adrenals, our pancreas, our stomach, our duodenum, our ovaries, and testes, but these are all part of the endocrine system, okay? And again, not a lot we can do in the pre-hospital setting about these, but we do deal with some sicknesses that are involved with it. So, when we look at the pituitary gland, anything we can do about that in the pre-hospital setting? No, they got to go to somebody who's a specialist, a doc, right? But what does it do? Well, it deals with all these hormones that help us grow, that keep homeostasis intact. And then the biggest one is there's also the pituitary gland also takes care of thyroid at the bottom, but again, not a single thing on any of that we can deal with. All right, we just know there's hormones and the pituitary gland does that. And you're not going to go on a lot of 911 calls or emergency calls with that. The other one is the thyroid gland. Again, maybe you have a mom or a sister or a wife that is on thyroid, right? Because of too much or too little. So anything we can really do about, and there's not a lot of 911 emergencies based on thyroid, right? But as part of our history allergies meds or our OPQRST and sample, we get that. So we want to have a good thyroid. You're going to get checked out on your thyroid when you do your yearly exams, but it helps keep your calcium levels and maintains those normal calcium levels, your energy. But the pancreas, okay, this is one. Now let's talk a little bit about this, something we might have to deal with in the pre-hospital setting. I wish, and hopefully at some point, maybe, they'll be able to clone a pancreas, you know? If they could do that, I know, it may be ethical or unethical, I don't really care. As long as diabetes is such a horrible deal because there's so many people that have it, and then there's people who abuse their bodies until they get the type 2 diabetes. So tell me, how many types of diabetes are there? Yeah, all right, so let's go with one type.
Type 1.
One?
Type 2, gestational, 1.5.
Okay, all right. We're not probably going to talk about 1.5 a little bit, but we will talk about 3 of them today, okay? So basically, our pancreas is in charge in the islets of Langerhans. They secrete hormones, and the hormone that we're looking for is what? Insulin, right? Okay, and the best way to explain this is that the cell, and I'm probably going to go through like 4 or 5 slides here, but real quick, but the cell has to have a key to open it up so that sugar can come in and it can utilize that sugar and oxygen to create energy, or ATP, okay? It's kind of a weird thing, but if you don't have that insulin, you can't open up the cell. and then people can't utilize that energy, so it changes their level of consciousness if they're diabetic and they can't get enough sugar and oxygen to their brain. It messes with all of their body organs, so it's pretty important. So insulin, however, there's a couple things with insulin, and we'll go more about our treatments in a second. I'm going to play this video. Hopefully the sound's going to come up. I'll play it separately if I can.
In this film, we're going to explain how your body processes the food you eat in order to provide all your body cells with the energy they need. And also what happens when you have diabetes and this system doesn't work properly. When you eat food that contains carbohydrate, it's broken down in the stomach and digestive system into glucose, which is a type of sugar. We need glucose from food because that's what gives us energy. Carbohydrate-containing foods are things like starchy foods, sugary foods, milk and some dairy products, and fruit. This glucose then moves into the bloodstream, and the body detects that the blood glucose level is rising. In response to that, the pancreas, which is a little gland that sits just underneath the stomach, starts to release a hormone called insulin. And it's insulin that helps our body get the energy from the food we eat. The bloodstream then takes the glucose and the insulin to every cell in our body that needs it. To make this easier to understand, let's look at muscle cells. At the muscle cells, it's insulin that allows the glucose to get into the cells where it can be used for energy. It's a bit like insulin as a key unlocking the door to the cells so the glucose can get in. That way, the blood glucose level starts to drop. But the blood glucose level can be topped up at any point by the liver releasing extra glucose that it has stored. The blood glucose rises again, and again, the pancreas produces more insulin to move with that glucose through the bloodstream to the muscle cells, open the doors, and let the glucose in. The body functions best with the blood glucose at an optimal level. It doesn't like it if the blood glucose rises too high. Normally, there's a cycle within the body which balances out the glucose and the insulin level, and this is achieved by the food you eat, the pancreas, and the liver. However, in some people, the system doesn't work properly and they develop diabetes. There are two main types of diabetes, type 1 and type 2. In type 1 diabetes, the body isn't making any insulin at all. This is because of an autoimmune response, whereby the body has destroyed the insulin-producing cells in the pancreas. We don't entirely know why that happens in some people and not in others. Type 1 diabetes accounts for about 15% of all cases. It's most often found in the under 40s, and it's by far the most common type of diabetes found in childhood. In type 1 diabetes, the carbohydrate-containing food is broken down into glucose as normal. That glucose then moves into the bloodstream. Normally, the body will produce insulin to let that glucose into the cells, but in type 1 diabetes, there is no insulin being produced, so the glucose can't get into the body cells at all. So the level of glucose in the blood rises and rises. The body tries to lower the level of glucose, tries to get rid of the glucose through the kidneys. That's why people who have undiagnosed type 1 diabetes tend to go to the toilet a lot to pass urine. As the kidneys filter the glucose out of the blood, they also take a lot of water with it, so the person with diabetes will get very thirsty. The urine contains a lot of glucose, and that creates an environment where it's quite easy for bacteria to thrive, so it's also quite common to get thrush or genital itching. In the same way, the blood contains a high level of glucose as well, so more bacteria than usual will tend to breed in flesh wounds, and they might be slow to heal. Glucose can also build up in the lens at the front of the eye, causing the liquid in the lens to become cloudy. That can mean that some people with undiagnosed type 1 diabetes can have blurred vision. Because the glucose can't get into the cells to be used for energy, somebody who's got undiagnosed type 1 diabetes is going to start feeling very tired, lethargic and unable to sort of go about their normal daily routine. But the body still needs an energy source in order to work properly. So what it does is it starts to break down its fat stores, and that can lead to weight loss. So the main symptoms of type 1 diabetes are going to the toilet a lot, thirst, thrush or genital itching, slow healing of wounds, blurred vision, tiredness and weight loss. These symptoms generally happen quite quickly, often over a few weeks, and can be reversed once the diabetes is treated with insulin. Type 2 diabetes accounts for about 85% of all cases in the population. It's most common in the over 40 age group in the white population and in the over 25 age group in the black or South Asian population. Type 2 diabetes is a little more complex because there's slightly more processes at work. Either the body isn't producing quite enough insulin, or the insulin it is producing isn't working properly. That can be due to being overweight because a build-up of fat can stop insulin doing its job properly, but it can also happen in people of a healthy weight. So in type 2 diabetes, the carbohydrate-containing food is broken down into glucose in the stomach and digestive system as normal. That glucose then moves into the bloodstream. The pancreas starts to produce insulin, which moves with the glucose through the bloodstream to all the body cells which need glucose for energy. However, the glucose can't always get into the cells because the locks to the cell doors have become furred up with fat deposits. That means that the insulin can't open the cell doors properly. So the level of glucose in the blood continues to rise. In response to this, the pancreas produces even more insulin. So the blood glucose levels continue to rise and the insulin levels continue to rise. This situation is further complicated by the cells, who are desperate for energy, sending out emergency signals to the liver to release stored glucose. The blood glucose level goes up, and the pancreas produces more and more insulin until it can't cope anymore and eventually it wears out. As with type 1 diabetes, the symptoms of type 2 diabetes are going to the toilet a lot, thirst, thrush or genital itching, slow healing of wounds, blurred vision, tiredness and weight loss in some people. The symptoms for type 2 diabetes come along very slowly, and some people don't have any symptoms at all. So for that reason, people can live with type 2 diabetes for up to 10 years before they realise that they have it. Type 2 diabetes can be treated in a number of different ways. Initially, it may be sufficient to make changes to the food you're eating and to take extra physical activity or lose any weight that may be appropriate. But type 2 diabetes is a progressive condition and most people need some form of medication to treat it.
Okay, so I hope that, I can sit there and give you tons of slides, and hopefully that gives you a better idea of what it's like, right?
So I'm not going to spend a ton of time on the slides unless anyone has any questions. I think that presented it pretty well. Go ahead.
The only question, with type 1, is it always congenital, you're born with it, or will it manifest where it's autoimmune? Can it manifest at any time?
Type 1 usually is congenital, right?
It can manifest at any time.
Yeah, it can
So-
manifest anytime
Yeah.
but it could happen all the way until, like, say, you're almost 40, right?
Or even older.
Yeah.
I've known people that are 50 when they find out they think they have type 2 and they're type 1, but it's primarily, they used to call it juvenile diabetes because usually it's kids that get it. There's some trigger, whether it's a virus or something in the genetics or some autoimmune trigger that causes it to manifest, and then it's very fast. My daughter, when she was diagnosed, it was 4 days from the onset of symptoms till she was diagnosed.
How old was she?
She was 9 years old.
And I should probably use a proper term. It's a immune disorder.
It was an autoimmune.
Yeah, so what happens is and again, they're not quite sure why it happens on type 1. But type 2 is more preventable.
Lifestyle?
Yeah, and you saw about 85% of it is type 2. And again, I really honestly believe it's just and I'm not making fun of Walmart or anything, but where we buy our food and the types of food that we get now, I mean, if I want to have anything out of season, I can have it. And if I want to have anything processed, I'm going to have it. And the cheapest foods are usually processed and easy to do, right? So, you know, you can have your TV dinner all the way up to really healthy food. So I think it's really difficult for all of us to try to keep on top of that, because I mean, even like if you try to have a good diet, you can't go to a C-store or like a gas station and find what you want, right? You might find some hard-boiled eggs and maybe some iced tea.
$5.
Yeah. And almost every single drink in that cooler has high fructose corn syrup in it, right? Not very many of them don't have it. And then even if you want a stevia, you've got maybe one drink that has that. So it's like so wherever we turn, we are overloading ourselves with that extra sugar and whatever we eat, okay? And I don't even know, I don't know if aspartame in the long term is going to say, it's going to cause. I know right now, if I want to do a keto diet, if I drink a Diet Dew, it kicks me out of keto. So I know at this point, aspartame has fooled my pancreas into thinking it's sugar. So, okay, cool. All right, so everyone understands. I don't think I need to go through all of this. What happens though is the cells in the pancreas are damaged and in type 1, and they cannot produce that insulin. Where in type 2, our bodies become resistant to the insulin. Okay? See, I think we've already talked about this. We can also get extra levels of glucose from our liver, and that's really important because we're going to talk about we treat in the pre-hospital setting by squeezing the liver for that last bit by something we have in our box. Okay. So one is that there's too much, and that's because we keep overloading with sugar, and then we become resistant, and then the pancreas makes more and more and more insulin, or the organ doesn't give us what we need, and it's been damaged in some way. All right, I think we've done that. Okay, so the other thing is, because of, and I talked about some of the signs and symptoms. So the first time I saw this as a paramedic, I was doing my ride-alongs at Orem, and I got to this place, and there was this old guy in there, and he was probably late 40s, and his legs were amputated and his arms were amputated, and he was in a crib, and he was having a diabetic moment, and there was no IV access at all, right? And I didn't realize it could get that bad. But that was the first time it just so happened it was my very first exposure to that, because I knew about diabetes, but I'd never seen it in this way before. And then we gave him glucagon because we couldn't get an IV. So I'll talk more about that when we start doing our treatments. So it can get that bad. Some people, when they have type 1, they control it very well. And they control it with their own insulin, and they are sometimes even more efficient, or just about as efficient as their own body is. So you got to think about that type of person in the pre-hospital setting. and then you gotta talk about the person that doesn't even care, or doesn't know what they're doing, and sometimes they take their insulin, sometimes they don't take their insulin, or, they don't control their diet, or they let themselves go out. So, this makes a huge difference in our treatment when we get in the hospital, I mean, the pre-hospital setting. But the problem is, because they have poor circulation, they get the neuropathy, they get the poor healing if they've hurt themselves. And sometimes I've seen this in our industry. We had somebody who had a diabetic moment probably every single day, and the medics finally would just go in and they would just drill her with the bone drill, and then give her sugar. So, I would say, is that the best for the patient? No, because eventually she ended up dying, but and she died because you're going to have cardiovascular disease. You probably have stroke. So it just gets worse and worse and worse. And I see sometimes the medics will just punish that person, especially if they're habitual and it's 2 o'clock in the morning. And so I caution you, don't do an IO on a diabetic. Use the glucagon instead. You're going to be there for, it's actually 14 minutes and like 27 seconds. I mean, it's pretty close to that. It takes that long for them to come back around, if you can't get a vein. Ideally, getting a vein is the best, but we'll talk more about those treatments in a second. So anyways, there are a lot of complications along with that. Always go BLS before ALS. Give them their oxygen, take care of their airway and all that stuff, because sometimes they're out and you got to take care of that. So sometimes there's chronic, sometimes there's acute, and some people will go ahead and waste away and go into death at some point. They'll have stroke. So someone with diabetes, likelihood they're going to have a stroke if they haven't controlled it for lots of years, right? Likelihood they're going to have cardiovascular disease. Likelihood you're not going to be able to get good IV access, right? All those things. All right, so we've already talked about insulin dependent. Some's hereditary. Some people, again, type 2. Insulin pumps. What do we do with those? Okay, I think I got my pictures. What do we do with it? What about insulin pumps? What do we do? I mean, they're a little bit intimidating. We don't know what to do, right? We're like, yeah, yeah.
But they or the family should know more about it.
Yeah. So the mom and dad ought to be like 100%. Go ahead.
I disagree with the last one, where it says to clamp it unless they're low, because so just like you said, the liver is always producing glucose in the bloodstream, and so a diabetic that's type 1 always has to have their insulin, because otherwise the sugar that's coming from the liver has no way to process. So if you clamp off their tubing, they're going to go sky high, and that would kill my daughter in about 3 hours. So you don't clamp it.
So
leave it alone.
Well, okay. So here's the thing. I've seen 4 different situations. One where they pulled their tubing and that's not working. The other one is that the machine is pumping insulin and they're not keeping caught up. And so the other one is it wouldn't turn off, or the battery died, not the battery died, but it just died. So they weren't getting any insulation and they didn't check it out. So with your pumps, again, your family is going to be there most of the time. It's just like some of the airway stuff that we deal with and pediatric genetic defects that we deal with. Mom probably knows as much as the doctor, right? And you can get up most of that information. But just make sure that you keep the pump in mind if you're having a diabetic emergency, right? And always ask about it. And again, we'll talk about more of our treatments in a minute. Okay, so a lot of people, they check us every year. All of us full-figured guys are always checking what on us? A1C, right? And seeing if it's coming up or creeping up. Well, you saw in the video that our body will continue to do this for years and years and years, and then done, right? So your A1C is something you should be monitoring all the time, okay? Again, like I said, probably the best diet is a ketosis diet for right now, if you feel like that way, or that's something you're having a problem with, because you're not bringing any kind of sugar in at all, and not having these spikes. And hopefully it's using your fat to burn too. All right, so the risk factors would be 45 and older, being overweight, family history, but losing 5 to 7% of the body weight, and at least 150 minutes per week in exercise can help prevent that. Your type 2. Yeah. So, there you go, 150 minutes of physical activity per week. Yeah, not too bad. All right, and then there's gestational diabetes. I've seen a lot of this, and the movie stars have it. Like, okay, who's one that has it that everyone knows of? She's kind of crazy. Used to married to Brad Pitt. Yeah, she has gestational diabetes as well, but she does some weird stuff too. So this happens when the pregnancy happens, a huge release in hormones happen, and then at some point they get high levels of glucose. This also enters the fetus, and then the fetus wants to increase its insulin. So they put a lot of these pregnant gals on a high protein, low carb diet. Okay? All right, so hypoglycemia and hyperglycemia. So hypo meaning low, so not enough sugar. So some people just don't get enough sugar, and then their body's like, hey, I need this. Or having too much. So everyone understand hypo and hyperglycemia? Okay, cool. And then ketoacidosis. So when you have hyperglycemia and you're diabetic and you can't get rid of that, then you go into something called DKA, or and this is where your body wants to use the fats to make energy, sadly, at the very beginning of my career, one time, I was working at Gold Cross, and I worked in the city most of the time, and we rolled up on this kid, and he was like this little kind of Rastafarian wannabe, and we went in his house. It smelled like they were smoking pot all day long, and he was laying on his bed, and he's acting weird, and the guy's like, stoner, drug addict, get him, and then take him to the Reach, because the Reach is where they dumped all their crappy patients, right? And so we didn't do OPQRST sample. They didn't even do a basic set of vitals. They just said, get up, walk, sat him in the ambulance, take him to the Reach. So we got in there, and my partner and I decided just to go ahead and do just a basic set of vitals, because we're going to have to call the Reach anyways, and they're going to kill us. And our device for blood glucose wouldn't function. It just kept saying error, error, error. I'm like, well, that's weird. So we get him there, and sure enough, he is in DKA. And they're like, did you guys even know this? And I'm like, I think we made a mistake, right? But we didn't know his history, allergies, meds, and we didn't do a good job of doing that. So you want to make sure that you do a really good set of vitals on everyone. And blood glucose should be a part of every single set of vitals that we do. And if they're having a stroke, why would we want to take a blood glucose? Or if you suspect them of stroke.
It might be a hypoglycemic
It might be a hypoglycemia or it might be diabetic. So, all right, three things, and I'm always going to tell you this. 3 things to say, this is a shouldn't and getting call. You've got to take care of it. This is your time to get paid to do your job, right? One is altered level of consciousness, right? Yeah, shouldn't and getting call. All right, okay? So, altered level of consciousness. Hemodynamically unstable. So, in other words, their colors are bad or they don't have a good blood pressure, right? And last but not least is you anticipate having to get an airway. Anytime you see those three or one of those things in place, that's the time. Okay? That's what we get paid to do. And so always get a blood glucose, because a stroke is altered level of consciousness. Diabetic issue usually is an altered level of consciousness. Getting hit in the head is an altered level of consciousness. Drinking too much alcohol is an altered level of consciousness. But they all present a lot the same. So we got to do a good set of vitals, good history, allergies, and meds, marry all that information together, and then come up with a plan. Okay? So we've talked about diabetes and why they want to, while they'll urinate, they'll try to blow off their sugar, so they'll have this different kind of breathing called Kussmaul respirations, right? And then sometimes they'll have, what does polyphagia mean? It eats the cells, okay? So I think we're all good with that. We've all talked about all these things. All right, so now let's talk about the assessment and how we would treat them. Okay, so this is something we have in our box, and we can actually make a huge difference here. All right, so what do we have in our box to take care of hypoglycemic emergencies and diabetes? What do we have? Glucose, okay? And what else do we have? Costs like $150 every time you use it. Glucagon, okay. All right, so for someone who has type 1 diabetes and they control their diabetes really well, but let's just say perhaps they took their diabetic or they took their insulin and then they went upstairs to eat, but then someone called them on the phone, and then they're talking on the phone, all of a sudden they go out because the insulin came in, took care of all the sugar that was left, right? And then they have that diabetic moment and go out. What will they present like? Are they going to be red, or are they going to be pale and wet? Okay, so that's one thing you can, but it looks like a heart attack too, doesn't it? Right? So with that person, and you know, Wade, my chief officer, is pretty public about his son and his diabetes, right? It's on Facebook, so I feel comfortable in talking about it. He was supposed to teach this class, right? And so I'm sure he would have brought this up. But so if his son went out, and this guy literally monitors his kid's blood glucose on his watch, on his computer. He knows where he's at every minute of the day. Probably better than anyone in this whole state, honestly. I don't know very many people that are that diligent. Okay, him and his wife are pretty diligent. So we get to his house. Wade's not there. All right, his mom's not there, and we figure out his blood glucose is 20. Right? What do we want to do as far as treatment? Airway, breathing, circulation, which I love. Put the oxygen on. IV access if you can get it, but this kid's pretty healthy, so you're probably going to get a good IV access, right? Okay.
Was he conscious or unconscious?
I think he's 8 or 10. Let's say he's almost unconscious, right? All right.
20 doesn't necessarily mean they're unconscious either.
It's all
Yeah.
level dependent.
Yeah. Let's just say he's altered level of conscious, not able to eat anything. Okay? Because we'll talk about that for a second too. Okay? So worst case scenario, he's pale, he's sweaty, he's out. Get his history. No one's there.
We're going to check his sugar, it's low. We're going to
Okay.
IV access and do some D25.
Okay? D25 or D50, right?
Right, whichever.
Okay. So now the question is, do I give him the full D50 or do I give him half?
You say full, right?
Okay, so, well, what I'm gonna say is, Wade would light it up if I slammed him with the full D50, right? So, here's the thing, I'm gonna walk you down a pathway, but this is where your green patch is you have to critically think through this, okay? Alright, so, number one, if I slam him with that full D50, his blood sugar is gonna just go through the roof. It's just like I gave him straight sugar water, right? Okay? And then he'll be doing this for the next couple hours, going up and down to try and control himself to get himself normal. Okay? So the idea is, the problem with some of our medics is what they'll do is they'll give him half and they don't come up. And then they'll say, okay, let's go ahead and transport him. Now, would Wade want us to transport his kid? Or would he want him to get him to normal intensive? I mean, of course, if the kid was sick, we'd want to go, you know. But do you think, you have to critically think through the whole, do I bring him halfway up and then sit and wait for a minute, see if he comes up? And if his blood glucose doesn't come up, after I've checked it after 14 or 15 minutes, and then give him the second half, okay, have I done anything wrong? And then he comes up, and then he's conscious, alert, and orange times 4. Have you done good? Yeah, okay. So you just didn't slam him, and he doesn't do this, right? Some people are uncontrolled. My thought process is, okay, let's go. We had this gal that did this all the time, right? No matter what, I'd give her the full thing, right? Until she came up. And then we'd sit with her and have a peanut butter and jam sandwich, drink some milk, wait there for another half hour, 45 minutes until she's normal, and then we had a sign of release, okay? So all I'm telling you right now, and then I had a medic at one time. It was a cop. Cop had a diabetic moment, type 1 diabetic. He went out at work. He gave him half, and he didn't come around. So he says, well, we got to transport him. I'm like, no, dude, why don't you just give him the full thing? No, I don't. I'm not going to give it to him because I've been told I cannot do this. I'm like, dude, he's going to be pissed at you when we get over to the ER. So en route, what does he do? He gives the other half. Guy comes up and goes, dude, why'd you transport me, right? All right, so does everybody understand you got to critically think through this whole thing? All right, so whether to give them a full amp or a half amp really is up to your critical thinking skills and what you have to do that day, right? And what's best for the patient. Don't send them on a roller coaster for the rest of the day if you can do it, okay? So work through that whole thing with them. Okay, so what if you can't get IV access? Now let's not talk about Wade's kid because not going to that kid usually is going to get IV access. Okay, let's say you've got somebody who is like my guy in a crib with no arms and no legs, or somebody who's just really in bad shape, right? Super fat, super no veins, every single one blows. Obviously, you've tried 2 or 3 times, can't get one. What is our next line? Glucagon, okay? And I'm not kidding you, it takes anywhere between 14 and 16 minutes. So once you give that to them, you have a waiting game. All right? So, give it to them. You want to go ahead and transport them right then? Because you know what's going to happen, right? How long will it be before they come back alive? 14 to 16 minutes, all right? So you sit down there with them, you wait, and then a lot of my medics will say, okay, you're back alive, sign a release and go. Do you want to maybe check their second blood glucose? So at least 2 blood glucoses, right? So I don't know why guys get lazy. You know, I'm there, I get paid to be there, I might as well take good patient care, right? But what have I done at this point now that I've squeezed their liver and got rid of all the rest of their glucose? Are they doing this now? They're going to be doing that. So last resort, because you're going to send them through the roof too. So everyone kind of understand you really have to have good critical thinking skills through this. It's not just, oh, diabetic, I see it, slam, done. Any questions? Go.
What are your thoughts? I've had a medic and I haven't seen him actually do it, but talked about taking 50 mLs out of your bag, hang a bag, take 50 out, put your whole lamp in there, run your drip until you get that sugar back, and then you're not about the time you get the sugar where it needs to be, you just shut your drip off and you're there.
Okay, so at the end of the day, here's how I answer that question. There's nothing in my protocol that allows me to do that. Okay, and so at the end of the day, when someone does something, I have to ask, did they do the protocol or not do the protocol? That is somebody swagging, scientific wild ass guessing, okay? And is it the right thing? Probably. But if something were to have gone wrong, he can't back himself up on that. And he probably has a family member who's diabetic, and he's probably going beyond the mark because he wants to try and take care of that patient even better. What his treatment modality is probably not wrong, but there's nothing with our protocol that saves him from doing that.
So not bad.
Yeah,
Just
not bad.
Not defend.
Pardon?
It's not defend.
Yeah, you can't
It might
defend.
be great,
Protocol.
it
Yeah.
might be the best thing in the world, it's not
Yeah.
defend.
Yeah, you can't do it. Like, for example, and you may have seen this in your career, some medics will have somebody who needs an airway, and they say, oh, I need to sedate him and take away his pain. And they slam with 2 meds.
RSI, but not RSI.
Yeah, and they do a fake RSI in the field. So, and, you know, if you're a helicopter guy and you take someone's ability away to breathe, so paralyze them, and you take and make them have an altered level of consciousness so they can't control their own airway or their own secretions. And then I don't get that airway, I've got a cold, clean kill right there. I did it, me. And so these guys mix these 2 drugs and say, hey, I just did an RSI in the field. That was really nice that you did that. Maybe that was the right thing to do in your head, but if that patient died, you can't defend that at all. But I will tell you, like if I was on a fire and I got burned and I had, you know, I'm laying there and you can see I'm swelling up, some guys might be that aggressive and take care of me that way, right? And do a pseudo RSI in the field. And they may have saved my life, right? But if they don't get my airway, they just had a cold kill right there. So all I'm saying is stay within your protocol. And right now, you get to be within protocol. Know that protocol so well. At this point, have it in your head. Read it all the time. Anytime you see them doing something, just or you want to do something, if you stay within your protocol, you're golden. Everyone good with that? Okay, cool. Okay, so a couple things they don't talk about. What if you wanted to kill your ex-wife in the middle of the night?
They don't talk about
Yeah, they don't really talk about that. But I've gone on these calls, all right? So somebody was telling me she had a whole bunch of expired insulin. And I thought to myself, if I only had that 5 years ago. Okay? No, just kidding, right? But the problem is some people could go ahead and overdose you on insulin, and then your sugar goes down and you go out. Right? Every cell opens up, takes all your sugar. So the first time I saw this guy wanted to kill himself, so he took all his insulin, gave it in his stomach, and we get there, and we're trying to figure out what's going on with him. His blood glucose kept staying way below 20s, and there was no way to keep up with that. And he ended up having cardiac arrest and dying. Okay? So know that some people have used that insulin to kill themselves. And so that's why they don't allow us just to go out and give insulin. That's why they're really stickler about that. Because if you don't know what you're doing, you can really hurt somebody. Okay? All right, scene size up, be safe. Sometimes when someone is having a diabetic moment, sometimes you'll get them they become aggressive and they may fight you, okay? Sometimes somebody may have alcohol on board and have a diabetic moment, okay? And so they may be aggressive. So the biggest thing is an altered level of consciousness is warrant for a good OPQRST, a good sample, a good set of vitals, including a blood glucose, and then coming up with an idea of how you're going to treat that patient. And this one is something in our box that we can fix all day long if they're don't have enough sugar. Okay, so what do we do if their sugar goes up and it's at 400?
And is that normal for them?
Are they conscious or unconscious?
Well, sometimes they'll be conscious, sometimes their blood pressure will be through the roof, sometimes they'll be a little off. The first time I saw this again, when I was a very brand new medic at Gold Cross, there was a gal that got in a wreck. She was ambulatory, walking around. She was just a little bit off, and we checked her blood glucose, and she was at 400. And we're like, okay, man, that's not normal. We checked it again just to make sure. Sure enough, we're at 400. Are you diabetic? No. Okay, well, she was undiagnosed, obviously, right? So this is where we need, we do a transport and let them know, hey, I think we have an issue here. No, she didn't have an altered level of consciousness, but she got in a wreck. Something wasn't all there for her, right? So, yes, so that's the time we're going to do some counseling. Backstepping. So on our hypoglycemic times, when we have that patient, where we bring them from an altered level of conscious to a normal conscious, then we're going to want to sit down and have that peanut butter and jam sandwich and a glass of milk, and then tell them, this is what we've done to you. And most will say, yeah, I got it, I already understand. And others will say, okay, how are you going to go ahead and manage yourself for the next few hours so this doesn't happen again, right? So just spend the time with them and send the engine home and sit there as you know, the ambulance and wait for them to get back normal, right? Okay. All right, so I think we've already talked about that. And then reassess. So if I can get you to always do something, make your main assessment, secondary assessment, reassess, especially on these type of emergencies. Okay, okay, so let's talk about oral glucose. How many times has anyone given that? Very often? Sometimes? All right, so here's the thing. Back to that whole altered level of conscious thing. If that person, sometimes they may be conscious learn oriented, like they might, yeah, I'm at my house. My name is John. What day is it? I don't know. So they're right on the edge. But if they're controlling their own airway, then this is a good time to go ahead and give them the oral glucose, okay? If they're not, I've had some people are like, okay, yeah, they're controlling their airway, they seem like they're pretty good. You put some in their mouth and they spit it at you. They're like, okay, we shouldn't have done that, right? But they're right on that edge of having an altered level of consciousness and either getting angry or not. So, again, it's only if you feel like they're controlling their own secretions and they're alert, maybe not all the way, but alert, okay? All right, so a dose then, let's look at doses. We usually use D50 in the pre-hospital setting, so how much do you want to give? Everyone say half first? Half and watch? Okay, everyone's good with that? And then if they don't come up, then what do we do? Yes, have the patience to bring them up. All right.
Kurt, I have a question.
Yes.
Can you meet at 1 o'clock today?
Meet at 1? I think so. I didn't even remember St. Mark's, but yes.
It'll only be about 15 minutes.
Okay.
Just on calendar stuff.
Yes.
For next year.
Yep.
Okay.
All right. Yep. Okay. Do we slam it? No. Nice and slow. Easy push. Right. Okay. Okay, can we give, let's just say you had to get an IO. Can you give D50 through an IO, yes or no? Yes, you can, right? But probably not the best for the patient. What about IV access? What happens if you don't have a good IV site and you blow the vein and you have a big bubble of D50 growing on their arm? Okay, so sugar in the cells that, you know, isn't didn't get there through the veins, or through the capillaries, or through the red blood cells, is gonna cause necrosis, okay? Okay, the other one we wanna think about is if they're having a stroke. Stroke versus diabetic. What if they are really truly having a stroke and they're diabetic, they're in a diabetic emergency? Now, okay, it's now time for you to use your critical thinking skills. What do you want to do? They're at 20?
Still treat diabetic.
Yes. Everyone good with that? Still got to do it, because the idea is either are they having a thrombolytic or a stroke, or they're going to have a hemorrhagic stroke. We don't know. Can you tell out the pre-hospital setting? No. Okay. All right. So for neonates and infants, you're going to give the D10. For children 1 age or older, you're going to give the D25. And adults, we're going to go with the D50. Everyone go with that?
I don't think I've ever had to do that. How do you mix that up?
All right, so if I want to go with D25 for a 1-year-old, and I've got that D50, how can I make a D25?
Half.
Yeah, half it, and then fill it with normal saline. So simple, easy peasy, right? D10 is probably the best for your infants and neonates. So if you have 50, you would empty all of it except for 10 out, right? And then the rest would be your normal saline. Okay? Does that work for you?
Yes.
Okay. So you can use the D50 on everything. You can half it or empty everything out with it and make the D10. So you just leave 10 left in there. Okay? All right. Everyone seen this? This one so you have to actually open this up, mix it with the powder, shake it up, pull it out, and then inject it. So it's not the easiest thing in the world. Okay? But, again, a lot of people have them in their houses, and then we have ours. Where can you give it? IM. All right? Okay, and so the one thing about DKA, IV, and go ahead and give them fluids. All right, that's all we can do is try and dilute their blood, and by giving them more fluids. But again, be careful because their blood pressure is already through the roof. So again, you have to play this critical thinking game of, do I want to put them at 200 over 96, or do I want to keep them somewhere around 120 over 80, right? I think that's all. O2 IV monitor, and you can give your drug. Okay, so let's talk about hematology for a second. So you guys need a 10-minute break. There's probably like 15, 18 slides left and we can be done, or you can take a break. Okay. All right. Okay, so there are a couple things out there that are disorders with red blood cells. Okay? And one is where the red blood cells are shaped like a half moon or a crescent moon, right? Or a sickle, like they used to use to cut weeds, so they call them a sickle. And then there's ones where people have disorders that will make it so that the red blood cells won't clot together. Or there's some people that are on medications that clot everything, and now they're in trouble. Okay, so we just need to think about these ones. So these would be the 3 reasons why you might be called on a blood disorder in the pre-hospital setting. All right, so with our blood, it helps our respiratory system and nutrition. It helps us get rid of poisons. It regulates everything, and there's also defensive measures in our blood that get after viruses and antibodies and antigens. There's 3 parts of the blood. So you have plasma, red blood cells, and then white blood cells, and then there are also some platelets along in there too. And those are responsible for the clot, or getting things to clot. The white blood cells take care and kill invaders. The red blood cells carry hemoglobin, iron, and oxygen to our cells. And then the plasma is just a good fluid for it to all go through. It's the kind of the fluid that pushes it through all the body. So blood is formed in our marrow, in our liver, and our spleen will hold or break down red blood cells. And then also it helps produce white blood cells. There are different classifications with your blood. So you have the O, A, AB, AB, and it's negative or positive. What this means in a pre-hospital setting, nothing. What it means in the post-hospital setting, someone needs to match or type their blood, everything, right? So, so just be aware of it. And this is where they might give transfusions and help somebody who's lost a lot of blood. Ultimately, we've got to remember that every red blood cell counts. And if we're in the middle of a shock situation, excuse me, we want to have oxygen and blood glucose or glucose at every single red blood cell so that we're creating energy or ATP. So if we're in a shock situation, now we are not causing energy to go out to the cells or the organs or the brain. So what we can do in the pre-hospital setting is check blood glucose and also make sure there's oxygen on board. Okay. So sickle cell anemia is an inherited blood disorder, and then it can cause problems by clotting. It doesn't carry oxygen and sugar, and I got some pictures here, but it can cause problems with the spleen. All right, so normal red blood cells are round, and they look like kind of like a nice, perfect little donut without the hole taken out in the middle, right? Your sickle cells, they have this kind of half star or half moon looking thing, and they catch on things, and they don't carry the same amount of blood or oxygen and sugar that normal red blood cells carry. Okay, I think I got another picture. Here's some other pictures. So they might have congested vessels. They might have pain. They might be have dehydration. They might have an enlarged spleen. They might have an enlarged heart because their heart's trying to get bigger, so it can push more red blood cells because it wants to, it wants to compensate, right? They have chronic sickle cell anemia. They have life-threatening complications. Okay, so the biggest thing for us is we just have to be able to recognize that through our history, allergies, meds. You're not going to be able to walk up to someone, you know what, I know you have sickle cell anemia. I can tell you. But these are the complications. They can have strokes, gallstones, jaundice, problems with their spleen, necrosis in their bones, osteomyelitis. They can be very tolerant to opiates because they're not carrying around those pain meds as much. Well, the pain meds are not doing what it's supposed to do. Ulcers, problems with their kidneys, chronic pain, pulmonary hypertension, and renal failure. So these are all the things they could have. Okay, well this is like what? Every old person we go on, right? Okay, so, all right, so we've done a good history of allergies, meds. We're still going to check all those things. Signs and symptoms are going to be tired. The other thing too that it happens in African American, or well, we shouldn't say African American, of African descent. Okay, so Caribbean, lots of sickle cell anemia there. In our world, African Americans, but it's higher in your African American population. Okay. All right, anemia just means you don't have enough red blood cells, and you're not carrying enough blood and glucose to the rest of your body. Okay, or I should say oxygen and glucose. So older people get it. People that bleed a lot get it. People that are having disorders with their livers are not making enough red blood cells. Again, anything we can do with that in the pre-hospital setting, it goes back to every red blood cell count, so we just we check the blood glucose and put on oxygen. All right? So anemia will happen with a lot of older folks, okay? And some people will try to be better at sports by doing what? They add what?
Blood doping.
Yeah, they add more red blood cells so they can make their cells work even better, right? Okay. The clotting disorders, okay, and I don't even need to go through the slides on this one. Okay, so there's several reasons why we're going to have clotting disorders in the pre-hospital setting. One is sometimes people's hearts, instead of doing this, they start doing this. Okay, so this is a flutter, okay, or it does this, so that's AFib. And what happens is the blood will sit right here in the atrium and won't push everything through, and it'll clot. Okay, so they'll give them a blood thinner, so to stop that from clotting. And okay, that's great. So a lot of people live with AFib. There's tons of old people out there living with AFib. Another reason why they might give a blood thinner is because someone keeps having strokes or mini strokes, or they have deep vein thrombosis, or they actually create thrombosis in their after surgery, or they've been sitting for a long time, and so they give them a blood thinner so to stop that from happening. Because what happens, it throws it and it goes either to the lungs or to the brain or to the heart. So they make sure that those that blood thinner will stop that from happening. Okay, so great. Now they've been saved. They aren't going to be throwing clots. They're not going to be having pain. But a guy with AFib's driving along, and he gets in a bad wreck, and he hits the front steering wheel and has got a Honda on chest imprint on him, right? Because the airbag didn't go off because he bought an old car from somebody that redid the car and didn't put the airbags in there. Okay, emergency, because now he's bleeding inside, and our historyologist meds, he says, hey, I have AFib and I'm on a blood thinner. Okay, with a 20-year-old next to him that just got in the seatbelt, not a lot of injuries. Who's going to fly? The old man or the kid? Right? So we need to keep that in mind when we start doing, especially in trauma, right? Okay, another one, let's just say someone's on a blood thinner, they have congestive heart failure, and now they have a bloody nose, and it's like that big lady that's sitting in the lazy boy that has to lift her up, to get her out, right? She's a bloody nose, can't breathe, and on a blood thinner. Okay? What do you do now? You can't put CPAP on her because that's like contraindicated for someone who's bleeding out of their nose, right? Used to do, you could do oxygen, nitro, Lasix. Now we can't even do that. We put on CPAP, right? But that's contraindicated. So literally, this actually happened where I would take like a whole roll of gauze, and she would fill that, right? Okay, so she has high blood pressure. She's losing her blood pressure. So assess, get her main set of vitals, reassess, or you do a primary or secondary, and then reassess. So we're watching on this person. We're always watching what? Blood pressure, right? Always. And then, like I said, if they've been in a traumatic event, we really want to consider how fast we're going to get them to the hospital, because they don't need a red patch or green patch or blue patch. They need a blood insertion, and we need to figure out how to fix their blood situation, which they probably need more blood. Okay. Okay. The last one is go.
For the pre-hospital, what we can do if someone is on a blood thinner, they're bleeding, and they have low blood pressure, we do IV access and give them
Yes, so, okay, that's a great question. So, if we wanted to increase their blood pressure, do we want to like just water them down so much? So, again, we're playing this game of trying to keep their blood pressure around 90, okay? And we don't want to dump 1,000 into them and water them down. So that's not going to help them, because it's going to help with their red blood cells carrying ATP out to the cells. No, right? So this person is a serious condition. So just keep that in mind, and no, that's why we have the golden hour. That's why we don't want to spend a lot of time on the ground. We want to try to get them in the right place. And yes, 500 at a time. Make sense? Don't just open it up and drop 1,000 into them. You want to watch that, assess, reassess, reassess, reassess. Okay, the other one is hemophilia, and I don't know if we're going to talk about that here. Let's see.
It's right there.
Back? Oh, there it is. Okay. The other one is hemophilia. This is a genetic disorder where their body cannot clot. Okay? So, this person we need to worry about, there's two classifications, A and B, but the signs and symptoms are the same. They can have chronic bleeding, spontaneous intracranial bleeding in their head. They require blood and a surgeon. So they'll tell you that. So good history allergies meds, somebody who's been bruised or been in an accident. We want to say hemophiliac is someone we need to transport quickly. Some people will be on something that causes them to clot, right? So that person will still want to get that the history allergies meds, but then we might want to think if they're having thrombosis or something else. So it should be part of our assessment anytime we have any kind of blood issues, bleeding, trauma, stroke, and stroke is kissing cousin to diabetes, right? So that's why they're all kind of in the same sisterhood. Make sense? And that's it. The one thing is, make sure that BSI don't get the blood on you and your seat is safe. Okay, so I don't think we need to go through the rest of the management, because you're going to, bottom line is we're going to do our primary assessment, our secondary assessment, we're going to get our OPQRC and sample, we're going to do all our vital signs, we're going to take that information, marry it together, come up with a plan, and then we're going to transport. We can never go wrong with that, right? We get the right answer every single time. The guys that want to say, sure you don't want to transport, they take on all the liability that day of not doing a good assessment, right? And they might get away with it a lot of times, and they don't have to they get 20 minutes of paperwork instead of 35 minutes of paperwork, okay? I'm just telling you, make sure you primary assessment, secondary assessment, reassess, and always err on the side of treatment. You'll never ever go wrong, and you'll be a happy person, I promise. Okay, so that's all I've got. I'm going to send out an email on instructions to go to St. Mark's. I think you're my first one tomorrow. Okay? Yeah, both of you are, aren't you? So I'll make sure you have that information. Basically, you're going to go in on the north side, where the little, so it'll be the north, we'll call it the northwest side doors on that side. You're going to go in, go downstairs, and you're going to get your picture, a little badge, and then you're going to go out and go to the ED side. But you have to do that. So everyone's going to have to go in. I'll give you a time, and I'm going to talk today. The best time to be there. I'm not making you guys get there at 6 a.m., but I'd probably want to be there around 7, 7:30, 8, so I can get those badges done, and then go enjoy. The only thing I can tell you as far as being in the ED, they'll put you as far as the EKG techs and the techs that do the IVs. Be aggressive. Ask to try and get on as many as you can, right? You may make a mistake. That's fine. Wear your UFA stuff. Yeah, just if you want to, make sure you have a shirt that says UFA on it. And remember to be aseptic, learn as much as you can with them, and have fun. Okay, I'll get you guys more information before tomorrow, make sure, the person it will probably be Laura, her name's Laura Jones, and she's the educational liaison. So, by tomorrow or this afternoon, I'll send out an email with really good instructions. Hopefully she's got some better one. Otherwise, that's it. Okay, anyone feel like they got robbed today and not having to look at every single one of those slides? Do you all understand type 2 diabetes? Yes, you do? Everyone understands type 1, type 2? Okay, all right. Are we going to push a full amp or not a full amp?
No.
Okay, all right. But when it comes to Benadryl, hell, give them 50, right? I'm always about go big or go home, right? Smoke a bowl, smoke 4. Okay? Okay. All right, have a good day.
Thanks, man.
When I do my memory.
Yeah. Right,
Thank you, man.
see you guys. See you in a couple of weeks.
I'm very envious of you and your man.
Well, I didn't sleep the last 2 days, so.
Oh, well, I did sleep, I guess that's fair.
So John, how did your last day go?
Uneventful.
Yeah?
Yeah.
Oh, man.
That's kinda lame.
I know.
Yeah, it,